Welcome, everybody. Last meeting of 2019. Last meeting of the decade. So for agenda item number 1, approval of the minutes. I will entertain a motion to approve the minutes of the November 21, 2019 public meeting of the commission. Do I have a second?
Second.
All in favor?
Aye.
Very good. The commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Seeing none, I'll ask who's on the phone, if anybody. Who's on the phone? Thank you. Does the executive director or any of the center directors have any additional updates? Chris, you first.
Good afternoon, commissioners. I just have a brief update on the status of the Maryland Patient Safety Center work. In October, we updated you on the Maryland Patient Safety Center and the commission's role in designating the center for a 5-year period. The designation will expire at the end of this year, and you voted to extend that designation to the Maryland Patient Safety Center, Inc. until 420 days, or about the end of April. Since then, the staff has prepared a request for expressions of interest, an RFI, and that document has been posted on our website as well as on eMaryland. We haven't received any responses as of today, but the due date for responses is July 14th, so there's a little more time. Are there any questions regarding that?
You said July 14th?
I'm sorry,
January?
January 14th.
Okay.
It's about a 4-week period.
One of those J months.
Yeah, we have since we were before you in October. Ben and I met with the Maryland Patient Safety Center. They've submitted a final report, so we continue to work with the current center until we get through this process.
Paul?
So last month, Mr. Chairman, members of the commission, last month I was joined by Linda Cole and Regina Bodner of Carroll Hospice, and we did an update on use of hospice services in Maryland and some plans for future development of our state health plan in this area.
I recall that.
Wanted to provide a brief update and clarification on hospice use. So this is a table that you may remember was part of the presentation last month, and it's not an apples to apples comparison because this is showing a metric of hospice use for Maryland's 35 and older population, the bottom line on the chart, and we use in our state health plan a benchmark which is different, which is the Medicare use rate for the nation that we benchmark against. And so you can see that there's this gap between those two measures of use that's persisted over a few years. So here we're using data that's been developed by a company called Hospice Analytics, which has been vouched for by the Hospice Network as a reliable source of information. So here we're putting Maryland in the context of other states and the national use rate so that we no longer have this disparate set of metrics to compare with. So what you see here is that Maryland still lags behind the national rate. And what I'm showing here is the 5 highest use rate states and the 5 lowest use rate states. And that 34 in the purple column for Maryland is where we rank among the 50 states in terms of hospice use. So this is, again, Medicare hospice deaths over total Medicare deaths. And give you a little more context, this is where Maryland stands in comparison to the states that border on Maryland and the District of Columbia. Maryland is in purple. You can guess why. And then this last slide looks at the jurisdictional use rates in Maryland at the 5 highest and the 5 lowest. And in Maryland. And we actually had some information on the way we calculate Medicare use in Maryland for the jurisdictions. And as you would guess, the high jurisdictions and the low jurisdictions tend to be the same, even with that different use rate metric. But wanted to kind of give you a better direct comparison of where we stand rather than what we have in our current state health plan, which again is a specific formulation for use in Maryland that isn't exactly the same as the way Medicare the Medicare use rate would be defined.
But you showed a use rate here of 49.4% for USA mark. And the benchmark that we had used in Maryland previously was 35 and up. The benchmark rate was 50%. So it's 50% versus 49.4. It suggests that what we're using is in fact comparable to national rates, if I'm understanding it correctly.
Not that much different.
Right.
When you
0.6%
look at it using the same metric across the board here, the gap is a little closer than the previous comparison here. But
Is there any data readily available comparing use rates in states with and without hospice CON?
We could put that together using the hospice analytics data set.
That would be very valuable, I think, because it would be interesting to know at least if it impacts use rate positively, negatively.
What was that again? I'm sorry.
Compare states with and without hospice CON.
CON,
Use
yes.
rates. Yes.
Following up on that a little bit, is there anything that would indicate, I mean, there's clustering going on here. At the same time, I am a little concerned that the two lowest are both kind of Appalachian counties, far western of the state. Do we have any feel for what's going on there? Is there services provided in those counties or at a lower level? Or is it something else going on unrelated to kind of our jurisdictions?
These are jurisdictions, Allegheny and Garrett, which are at the bottom here, that are single hospice jurisdictions. There's only one hospice serving both of those jurisdictions, and they are geographically pretty large with low population density, so it might be a little more difficult to service those areas. But you go up to the third from the bottom, that's obviously a very urban and suburban jurisdiction.
Right.
With multiple hospices serving it.
Yes.
Which we've helped facilitate.
Yeah. But only 0.3 percentage point different in terms of use rate. So it's multifactorial, complicated problem.
Yeah.
Given what
Thank you.
we help facilitate in terms of increasing services in Prince George's County and Baltimore City, breaking these numbers out by race ethnicity, I think, would be important. Otherwise, it can be quite misleading when it's aggregated. There are certain pockets, populations not being served. And we need to be able to see that. So I'm not familiar with hospice analytics, but I'm assuming, correct me if I'm wrong, they have demographic information on these patients, yes or no?
I do not know if they have a breakdown of use by racial or ethnic groups. I've not seen that in the data set. In the presentation last month, we did show a racial ethnic breakdown of use nationally and in Maryland. And actually, what that indicated is that if you look at the use rate of African Americans, for example, in Maryland, it is actually comparable, maybe even a little better than what you see in the nation. But it's still low compared to the white population. And Maryland has a fairly substantial African American population, so relatively it does tend to bring down Maryland's use rate compared to the rest of the nation, even though if you just isolate on that particular group, we're not doing too bad.
Yeah.
But I think you're sort of asking the question, is there racial disparity in the use of hospice in Maryland? I got the sense from last month that question is not really a question. The answer is yes, for profoundly.
You just need to keep it in front of us because the strategies to close that gap are quite different than a strategy that might be a general overall strategy.
That's
And when
very
the bar is so low, we don't want a victory lap when we're just a little bit above the bar, it's just so bad. So we should be setting the standards.
Right.
When our two
Agreed.
lowest counties up there, and I could be wrong, we don't know the demographics, but I don't think the African American population is skewing the results.
Sir, I
And
think,
Garrett and Allegheny counties would have another issue, and it probably is socioeconomic there.
Or geographic.
Or geographic.
Or geographic, yeah, I think, and the more likely,
And that's fair.
well, yeah,
It's fair, but I mean, still, when we think of strategies to address, there may be one set of strategies for racial ethnic, another for,
but before getting too deep into the
Okay.
topic that wasn't on the agenda.
It's a hot topic.
It's a hot
come up
topic.
like
It's
3
a-
times.
It's important, but it's certainly possible that in jurisdictions with substantial geographic challenges and low volumes overall, like Garrett and Allegheny, that the bar created by CON in those jurisdictions is high enough to actually keep providers out, small providers who otherwise might be delivering services.
Yeah.
So I think that's something we need to also keep in mind as we look at this. And I'm taking advantage of the fact that I don't think any of the hospice providers are in the room right now to get as agitated as they were last month when I spoke. But I think we need to carefully consider this and comparing how we're doing to states that don't have CON in place, both from a quality standpoint, as they would argue, and from an access standpoint, as I would argue, is important. And I think it's potentially a different issue from the racial disparity issue, but the two issues likely cross-contaminate each other substantially.
so I will follow up with the hospice analytics data on states with CON regulation and states without CON regulation. I'll see how far down we can drill at the state level on racial and ethnic use.
I don't think you'll have much asking them about the racial ethnic, just because this looks very much like straight Medicare claims, which doesn't have racial ethnic on it.
So Commissioner Boyer, and then I think Kevin had a comment.
Just looking at the issue of CONs and not knowing the relationship between the CONs in Maryland and our neighboring states, if there's even a way to partner with our neighboring states in those edge counties, which are Charles, Allegheny,
Garrett.
and Garrett, to because if it's a problem for us, it's probably also a problem for Virginia and Pennsylvania, and it would be something that, working together, we could come up with a great strategy that serves the needs of everybody.
And there are also probably there's probably some comparable data about rural counties in other areas of the country, what's been successful, what hasn't.
Well, you look at Delaware, and then you look at the whole, the Upper Shore.
And Virginia on the Southern Shore.
Yeah.
Kev? Go ahead.
So I think it's oftentimes difficult on these regulatory issues to work across state boundaries, but keep in mind that Garrett Hospital has an affiliation with the University of West Virginia, and it may be ways, methods through that type of engagement that we can spawn some initiatives. Likewise, as I think most of the commissioners know, the acquisition of Western Maryland Medical Center is moving forward with University of Pittsburgh Medical Center. So if you look at the hospitals owned by UPMC, it kind of snakes down all the way to the Pennsylvania border, and then it's going to touch on Western Maryland soon. They're an aggressive system. I don't know exactly what they have in terms of hospice services, but I would expect, given they own a health plan, multiple hospitals, they're probably very vertically integrated. And have not had a conversation with UPMC, but we expect to shortly.
And Christiana is another example.
Yep. Kevin, did you comment? Okay. Ben?
Thank you, Mr. Chairman, on this historic commission, last in the century, last in the decade. So a few things, and these are just house updates. We did submit our 4-year insurance mandates report to the General Assembly after last month's meeting. In that transmission letter, the staff noted that several, in several commissioners' assessment, that several of the mandates offered in other states were not covered in Maryland should be considered. We also voiced MHCC's longstanding concerns that while the cost of any mandate was small, the cumulative impact of all mandates can turn out to be quite substantial. We have not gotten any further feedback. I understand that we do have a request from the House Government Operations Committee to brief them on the 4-year study. We did, however, receive a follow-up request on estimating the impact of a mandate, and that was that we understand that a sponsor is planning to introduce a bill that would remove cost sharing from prostate screening, both prostate-specific antigens and digital rectal exams are now a covered mandated benefit in Maryland today. What the advocates are proposing is to eliminate cost sharing for that benefit. We have received a letter, I think it's in your packet, from Delegate Petey Melnick requesting us to do that. It's probably something that we don't want to contract an actuary for, but we do it in-house, and we'll keep you informed as we move forward. It's something we want to turn around pretty quickly. We also will hear today the results of our actuarial study on the impact on premiums of establishing the 3 EMS models. You'll hear more about that, but we will meet the deadline of getting that to the legislature by December 31st. We've also sent a letter to our oversight committees that although we've made substantial progress on developing the inpatient and psychiatric regulations, we're not going to be able to meet the deadline of having regulations in place by the end of December. That's in part due to the work that the Maryland Hospital Association suggested that we take on, which was to drill down more deeply into these challenges of emergency department boarding, hard to place patients, and align some of the issues that relate there to changes in the state health plan. So I think it was time well spent. The additional information gained from our clinical advisory panel is going to be helpful in revising those regulations. And we look forward to moving forward with those in the first half of 2020. A small note, but something of interest, is that recently across the country, there's been a lot of interest in benchmarking primary care spending as a percentage of healthcare premiums. A couple states, including Rhode Island and Oregon, and most recently Colorado, actually have statutory authority to require private insurers to spend a certain percentage of premium on primary care. This is an issue that has caught the attention of Secretary Neal. Although we don't anticipate, or I don't anticipate any legislation, he's asked us to develop a metric so we could track primary care spending as a percentage of total cost of care. Certainly, it ties into the work that we're doing overall on the total cost of care model. We'll be meeting with folks from RAND and Bailiff Consulting over the next week to talk about how we might use their methodology to develop a metric that would meet the Secretary's requirements for keeping track on primary care spend. These new models do anticipate that patients, Maryland residents, would have a routine source of primary care. So I don't think it's a bad metric to to track and try to relate to what else is happening in total healthcare spending in the state. We would likely start with the private sector. That's where the most research has been done elsewhere, but it's kind of more important, I think, to look at the Medicare population as well. Staying with the theme of primary care, we did convene our Medicare, or our Maryland Primary Care Council last week. It was a productive meeting, although at times a little quite people voiced strongly held opinions on various issues. We did agree to form two subgroups to focus on new models. Keep in mind that the primary care model in Maryland has 2 tracks currently. There is not downside risk on track 1 and even not in track 2. Our colleagues at HSCRC, as they are held accountable for meeting some rough, tough spending targets, are anxious to move primary care practices along on these models. So we will be convening a subgroup to discuss with all stakeholders approaches for establishing potentially a 3rd track that would have downside risk associated with it. Therese has already talked about the Patient Safety Center, and we're working pretty aggressively to try to generate some interest in that initiative. My hope is, at the minimum, if we don't get other interested parties, that we build a broader coalition of organizations that would work with the Patient Safety Center to launch some more ambitious initiatives over the next several years. We also have a major grant, certainly the largest telehealth grant that we've ever released, that David and his team are working on. The letters of intent are due tomorrow, and the final grant proposals are due at the end of the month. And lastly, our collaboration with nascent organizations in the state continues. The governor's office had requested that we help convene the newly formed Prescription Drug Affordability Board. Work is going forward in identifying personnel structure, as well as taking steps to organize the first meeting. That will be held on January 15th at the Amos room in the Miller Senate office building. If people are interested in further information, please contact Megan Renfrew or myself, but it's likely that staff will have to provide some additional support for those first couple meetings as they get off the ground. That concludes my update.
Thank you, Ben. So I had a couple of comments as well. I know that you mentioned that staff are working diligently on the draft updates to the state health plan chapter on psychiatric beds, behavioral health beds. And this is a topic that has raised and will continue to raise a substantial amount of interest among stakeholder groups. And it's the first of a series of state health plan chapter updates that we're going to engage in over a period of time to proceed down a pathway of regularly updating the chapters. I think it's important that we sort of, as commissioners, set forth some of our thoughts with regard to what we expect in the process and some of our thoughts with regard to the process. So staff has some help in dealing with some of the special interest groups that they will certainly be encountering and working with. During the 2019 legislative session, the General Assembly passed legislation mandating that the Maryland Healthcare Commission begin a regular and deliberate process of updating the state health plan chapters within the Annotated Code of Maryland. The content of those chapters drives our analysis of all applications for certificates of need in the state of Maryland. In particular, the state health plan chapters give the commission and applicants direction when it comes to projecting the need for future bed capacity in any given specialty area and in any given jurisdiction. As the commission proceeds with the development of draft changes to the state health plan chapters, initially in the hospital psychiatric services chapter, It's essential that we as commissioners provide staff with direction in the development of those changes. Stakeholder work group meetings have been underway for some time now. Recently, the staff convened a clinical advisory group to gain more clinically relevant information about hard-to-place adolescent patients and geriatric patients with comorbidities. Staff are currently digesting the contents of the input from the clinicians. The input from the advisory group will inform the work group and provide guidance on how the hospital psychiatric service chapter should be modernized. Commissioners must understand the landscape that these regulations will influence and the importance of these regulations in supporting our objectives under the total cost of care model. Updating these regulations is critical, and the legislature has established a timeline for completion. As we update the chapter, we must steer clear of the rigid bed need methodologies that have been anchors of many state health plan chapters. Rigid bed need projection once represented the necessary counterbalance to a system of rate regulation that essentially guaranteed hospitals payments sufficient to cover increased depreciation costs that were associated with expansion of bed capacity in the context of older models of rate regulation in the state of Maryland. Since 2014, however, those models have changed dramatically. Since January 2019, not only are hospitals no longer protected from increase in future depreciation costs associated with future capital investment, as they were prior to 2014, they're now actually penalized for any increases in cost of care, either inpatient or outpatient, that accrue to Medicare beneficiaries under the total cost of care model. Given this important shift in the realities of the healthcare reimbursement environment in Maryland, it's essential that we as the Maryland Healthcare Commission shift with this changing paradigm and develop methods to evaluate CON applications that are consistent with the priorities and incentives of the total cost of care model. I'm pleased that staff has proposed eliminating a bed need methodology from the proposed chapter. I understand that some of the stakeholders are reluctant to abandon this methodology, but it's frankly no longer relevant, necessary, or valuable. I believe that our regulations going forward must provide hospitals with the greatest flexibility possible, consistent with the realities of existing statute, to increase or decrease the size of inpatient or outpatient facilities as necessary to meet the needs of their communities. Bed need projections are important, but not always accurate. Hospitals are responsible under the total cost of care model for the consequences of overestimating bed need projection, and they're therefore incentivized to get bed need projections accurate. It's important for us to recognize that hospitals are also penalized under the model for underprojecting bed needs. More importantly, patients are penalized when we underproject bed needs and when we become unable to deliver on the promise of ensuring access to care for populations. Each commissioner needs to carefully evaluate any draft regulations that are presented. I want it to be clear that I'll expect staff to develop draft regulations that maximize the flexibility for hospitals to project bed need, as long as those projections do not appear to underestimate the needs of the population. I'll personally evaluate draft regulations from this perspective, and I encourage you to do so as well. I note that Health General Section 19-120 does not require us to apply rigid bed need methodologies in our planning responsibilities. Bed need is not referenced in that section of the statute. We should use that flexibility in the statute to better align our health planning duties with the new realities of total cost of care. I encourage the commissioners to become involved in our state health plan development efforts. The staff welcomes commissioner involvement during the development process. Participation of commissioners at an early stage can provide signals to stakeholders on scope of update. You'll likely hear from constituent groups regarding their preferred approaches to this process. They're not bashful. There's no shortage of perspectives when it comes to health planning and CON issues. I encourage each of you to carefully evaluate what you hear in the context of the potential conflicts of interest associated with the various groups who will reach out to you. I encourage you to carefully evaluate what you hear and to consider the comments in the context of the total cost of care model and the mandates that Maryland is facing in that regard. In 2018, the House and Senate Oversight Committees told us to reconsider the health planning status quo and to align our planning processes with the total cost of care model. Vice Chair Sargent led a task force that made important recommendations for modernizing planning and CON. The oversight committees in the House and Senate supported these recommendations. It's our responsibility to take the next steps. Thank you.
Excuse me.
Yes.
When this comes in front of us, will we have any data of
examples when Con has underestimated the need, rigidity of Con, CON?
Try to understand the question exactly. Well,
You said that we may have, at times, it may be so inflexible that at times underestimating or purposely lowering the number of beds that would be needed. And will we have examples of that? That has happened? We're assuming it's happened. I don't know that it's happened.
I think there is potentially incentive for hospitals to underestimate bed need projection to limit investment in certain areas. Staff will certainly evaluate projections and give us assessments of the degree to which that may or may not be true. We've, in the past, focused far more on the other end, when hospitals come to us asking for more beds than is rational in a particular area. And in previous models, that made infinite sense that we would limit those things, because the hospital investment in that additional infrastructure led to additional carrying costs for the hospital in terms of depreciation cost. And that was going to be made up necessarily by the HSCRC and increased rates. So we were essentially giving them a license to get more money. In the current model, we're not. They're getting what they're getting under the GBR. If they build if a hospital were to build a brand new facility with 10 psych beds, and they currently have 40 psych beds, and they're sitting with a census of 98% in that 40 psych beds, one can imagine that that's going to create a problem for nearby hospitals in terms of where those patients are going to go, and it's going to create a problem for the community. That's the type of thing I think we need to continue to keep our eyes on. But when hospitals and communities come forward and say we need additional beds, the bonus, we're no longer protecting the state from,
I'm just curious if we've had some graphic examples in the past.
of underestimating bed need projection. I don't think so. I think of it as a risk when you put these models together. But Paul, can you think of any dramatic examples of underneeding? Yeah, no.
Yeah, I mean, I think that's an interesting question, but the examples I can think of only pertain to particular hospitals that have said we wanted to get more, we requested more, and based on our projections, we said this is what you need. I think a systematic evaluation's never really been done on that particular question.
At the same time, when we think about changing the incentive system, I mean, and now we're having a somewhat more cost-focused incentive. So, I mean, we know from other areas that quality and access are therefore somewhat vulnerable. If you have a system that doesn't worry about cost, so you just continue to build as many beds because the state will hold you harmless for doing that. The idea of, I guess I would argue against waiting until we have a problem to think through the incentives we're setting up. So to a certain degree,
I agree with you. I'm just curious.
I'm just, I think the idea of access, we may not have an example of where a particular hospital, I think we have examples of critical need for inpatient psych, and patients are having serious access problems in the state at very critical times, suicide watch, those sorts of things. But I think just in terms of being smart about, I think we've seen governments too often set up incentives that they never really intended to, and not really thinking through the full set of what counteracts what, how these things work beforehand, to be sure that they get the overall system-wide incentives right. And that's all I'm hearing Andy say right now is be smart about this thing. Don't set up a situation where we've overspent, because certainly my experience with the feds is once you've overspent the money, once you've getting it back again is murder. If you're smart about how you start out, the incentives are as close to being final as you can get them. You're just in a much stronger position, and better for patients and taxpayers.
So one thing I'd like to do is make a request that just as a commissioner who's not a health policy expert and have picked up a little bit here and there, as we get into all of these chapters, I would love to see a presentation. We're developing this chapter. These are the points that have been contentious in the discussions. We're not presenting you with solutions. We are informing you of the both sides of the debate. And if I knew those things as updated when the chapter comes before me, I will be much more informed about how to parse the issues. So it's sort of a request of maybe
A
we
briefing.
can.
Yeah, I think that's
So-
well put.
Oh, go ahead, Paul.
I think we definitely have typically tried to come to the commission, usually at a point where we've done enough work with a work group that we're ready to kind of put out a draft for informal review and comment. And we try to have a session at one of these meetings where we do brief the commission on what are the contentious issues or potentially contentious issues in the plan and how we address those with the work group. On your question, I think the risk of underestimating need is typically going to be greater when you have a service where we're seeing a fairly brisk increase in use rates and demand. And when you look at the institutional services that we project bed need for, in the last 20 years, with the exception of hospital medical surgical services, use rates have been coming down. Use rates have been coming down in the last 20 years for nursing home beds, and our bed need projections have been following them down. In the hospital area, use rates for rehab have been flat to gradually declining a lot for pediatric services where we do bed need projections. In the first decade of this century, we were actually seeing pretty strong growth in demand for hospital medical surgical services. And that was because the use rate, especially of the non-Medicare population, interestingly enough, was going up. And decline in average length of stay, which had been in a long-term decline, starting to flatten out. We weren't getting the kind of reductions in average length of stay that we had seen earlier. And to some extent, we dealt with that. So we were at risk there because of what we were seeing of maybe not supplying enough hospital medical surgical beds to meet demand. To some extent, we addressed that by lengthening the projection period. 2010 was when we first saw the baby boomers, that big age bulge kind of entering the population. And that was one of the reasons why we decided to, instead of doing a 5 or 6 year projection, we actually went out to 10 years, which retrospectively I would say is probably too much. But to some extent, we addressed the concern with underestimation by taking a longer look out to the future and doing the bed need projections. Now, since 2010, that's been reversed, and now we're seeing a broad decline in medical surgical demand for hospital beds. So pretty much everything now is declining. So we're not at great risk of underestimating bed need for the things that we project bed need for. That's kind of my take on the question.
Can I follow up on Randy's point, or kind of a friendly amendment? I think you're right, Paul, and the way you described kind of the way it's brought to the commission. But sometimes when you're already at a draft chapter, it feels like the cake's already cooked by the time we see. You've already talked to the interest groups. You already know where you as the staff want to go with this thing, and the momentum is to continue down that path, whether that's quite where we're all comfortable or not. So I would like to just support Randy's idea there, but just move that a little earlier in the process, so things aren't quite up to draft by the time you get commissioner input.
All right. I think it's a great model. All right, moving on. Agenda item number 3. The Certificate of Need Rehabilitation Hospital Corporation of America, LLC, doing business as Encompass Health Rehabilitation Hospital of Salisbury. Addition of acute rehabilitation beds. Encompass is applying for a CON to add 10 beds to its specialty rehab hospital in Salisbury and Wicomico County by renovating about 13,000 square feet and adding about 1,400 square feet, increasing the facility's bed capacity to 74 as well as significantly increasing the number of beds that would be in private rooms. Chief Certificate of Need Division Kevin McDonald will present the staff recommendation. Kevin?
Thank you, Mr. Chairman, and good afternoon, Commissioners. The applicant is Rehabilitation Hospital Corporation of America, LLC, doing business in Salisbury as Encompass Health Rehabilitation Hospital, Salisbury. The applicant is a limited liability company, subsidiary of Encompass Health Corporation, a publicly traded proprietary corporation with a network of 127 hospitals, 272 home health and hospice agencies in 36 states and Puerto Rico. The facility currently has 64 acute rehabilitation beds, and its primary service area is the counties of Wacomico, Worcester, and Somerset in Maryland, as well as Sussex County, Delaware, where close to 25% of its patients come from. The project would renovate 13,000 square feet, add about 1,400 square feet, and primarily using space that is in what was formerly outpatient physical rehab, which is no longer being used. 14 patient rooms would be added, and some of the semi-private rooms would be converted to private for a net gain of 10 beds, would increase the number of private rooms from 14 to 28, boosting their effective capacity, because single rooms are easier to use in admitting, balancing gender and specific needs of patients. The project would also add space to patient dining areas, therapy space, the business office, and the library. Cost of the project is estimated at about $5.7 million. It would be funded with cash. The previous discussion of need was interesting. In this particular case, the burden of proof was on the applicant because the proposal exceeded the current bed need projection by 5 beds. There are currently 84 rehab beds on the Eastern Shore planning region, leaving a minimum net need of negative 35 beds and a maximum net need of 5. And again, the application was for 10. The points made by the applicants as to why the bed should be awarded despite not complying with that bed need projection is their high occupancy rate, consistently in the low to mid 90s, significant in-migration from Delaware. They also provided data showing that they turned away close to 300 patients in 2018 for lack of bed availability, and year to date, it's about 260. There was also the factor that data showed that on the Eastern Shore, Medicare patients are diagnosed with stroke at a measurably higher rate than much of Maryland, and the incidence of stroke is heavily correlated with the need for these rehabilitation beds. During the review, staff had some concern concerning the comparatively high use rates per 1,000 in the Encompass service area. For the 65 plus cohort, the use rate was about 2.5 times the state average. And it was also 50% higher than the midshore counties of Talbot, Dorchester, and Caroline. In explaining this or discussing this, the applicant showed us that Maryland has a lower use rate than the national average, as well as neighboring states. Maryland uses about 60% of the national rate and is 36th among the states in the use of inpatient rehabilitation. There's a factor I mentioned earlier about the higher incidence of stroke. And as well, the applicant pointed out that their usage is highly regulated by Medicare in terms of reviewing charts and denying patients that do not meet the qualifications. So while the staff did have that initial concern, we do see that there's a lot of variation in use rates, at least some of which is likely attributable to, are these kind of beds even available to the population? Also, the projection methodology doesn't provide any normative use rate target or adjustment for appropriate use. And there's really not a basis for disapproving the project. Moving on to charity care, the charity care standard, staff did need to work with the applicant to align its policies, procedures, and forms with the charity care standard. The Encompass track record for charity care is that it was virtually non-existent. However, in its application, they did commit to a 2% level, 2% of expenses, which would be quite generous compared to the limited sampling of rehab hospitals in the state. They put forward a plan to improve their charity care performance that would involve their clinical liaisons educating local providers, especially the two area hospitals, Peninsula Regional and Atlantic General, about the availability of charity care, using meetings, phone calls, regular mail, and electronic mail to communicate with discharge planners about the availability, as well as physicians, nurses, and therapists about the availability of charity care. Ultimately, staff concluded that they did meet that standard, although we do have a condition to recommend that is related to the applicant's process for identifying the need for charity care as well as its results. And I'll give you the exact wording of that condition, recommended condition, when I wrap up. Looking at viability and financial feasibility, Encompass has demonstrated a capacity to fund the project through cash reserves and has generated consistently a healthy bottom line, and the financial projections show a continuing healthy bottom line based on utilization, revenue, and expense projections that staff found to be quite reasonable. There is no negative impact on other providers in the system at large, and a positive effect on access. Therefore, the staff concludes that Encompass Salisbury application for certificate of need to add 10 acute rehabilitation beds meets the general CON criteria as well as the specific standards in the state health plan chapter governing acute inpatient rehabilitation services. Project is needed, is cost effective, is viable, and will provide a benefit to residents of the service area without having an adverse impact on other providers. Therefore, staff recommends the commission approve the project with the following condition. In its request for first use approval, Encompass Salisbury shall provide information acceptable to commission staff that details the activities it has undertaken following approval of the certificate of need to increase the amount of charity care provided to patients, and demonstrates its progress towards achieving the 2% charity care target to which it has committed itself. If staff concludes that Encompass Salisbury's demonstration of progress is not satisfactory, further action regarding the certificate of need may be considered by the commission at a public meeting. We have representatives from Encompass with us today. Steve Wallace, the CEO, and their attorney, Carolyn Jacobs of Jacobs and Denver.
Thank you. Do I have a motion to approve the certificate of need application?
So moved.
Second,
Second.
discussion. Commissioner Blair.
When I reviewed the packet, I noticed that there's very little in there in regards to community input. I believe there was something from the Board of Health or the Health Department and one other individual, again, associated with the medical community. So as a whole, did we investigate to see if there's any other comments from the community impacted?
We didn't solicit any comments other than the health department. And we typically don't. it's really up to the applicant to generate that.
Any questions as to why the applicant didn't get any more community input?
No.
Thank you.
How many rehab hospitals are there in the state of Maryland?
The only other one I'm aware of is Adventist Rehab.
Okay, 'cause I saw the stats, so I just saw the payer mix is, Adventist,
As a
59.
freestanding, as a freestanding.
Freestanding, right, and they're about 59% Medicare, they're up to 80, almost 88% Medicare. Is their rates comparable? I mean, from a rate standpoint, are they, cost per patient, since it's mainly Medicare population, are we concerned about the rate structure at all? I know this is not an HSCRC meeting, but have we looked at their overall rates to see whether or not there's gonna be any impact, any change, are they fairly, cost efficient, any of those issues?
Medicare sets the rates for the hospital.
It's an inpatient facility.
Medicare still sets patients.
It's not rate regulated.
It's not rate regulated. right.
Okay. These are not.
They'd be subject to whatever
So
Medicare,
rather Medicare.
whatever
payments.
Medicare's
Okay.
standard inpatient prospective.
HSCRC does not rate regulate.
Got
More
it.
importantly, within this model, Medicare pre-approves the admissions. So for patients who aren't eligible for admission to one of these facilities, Medicare simply says no, prospectively controls the cost. That way.
So I'm thinking the reason why they're charity care, I mean, they have a very high Medicare population, so they're probably getting reimbursement for these patients. You know what I'm saying? There's probably less.
It's a good point. The eligible patient population is eligible for Medicare.
Right.
Although I would like to commend the staff on their focus on charity care and making sure that there's follow-up and oversight. And if there is anything, certainly feel free to bring it back. We would encourage that. I would anyway.
Commissioner.
So I was reading something else, trying to understand charity care a little bit more. How do most entities process charity care? Is it first they bill the patient
No.
first?
No, that would be considered bad debt, and that does not get recorded as charity.
Okay.
Charity care is basically the patient has to request that, has to identify that, they would have trouble with the bill. And our standard holds an applicant to having a policy wherein they will make a decision on probable eligibility within 2 days of receiving a request. And our expectation is that that request doesn't require documentation, but is more of either a conversation or a very simple form where the patient gives you an estimated income, number of people in the family, things of that nature. And then the facility is in a position to compare that to the poverty levels and tell them that, yes, according to what you've told us, it appears you'd be eligible for charity care at whatever level their policy would show. They are, however, able to then say that there is a final determination in which you might have to document your income, what you've said. But the initial 2-day determination needs to happen without a lot of trouble, without a lot of documentation. And then once that is completed, it's allowable for the facility, certainly, to say, okay, you need to give me some documentation that what you told us is accurate.
And that's across the board for all entities.
That hits virtually all of our state health plans. The only one it doesn't is the psychiatric beds. There is a little bit of a different standard there, which is that the applicant needs to show that their provision of charity care is comparable to others. So it's more of an outcome based than looking at their procedures.
Kevin, do we distinguish between for-profit entities and not-for-profit entities with regard to the charity care requirement?
We don't.
It's important to keep in mind this, that they're paying taxes in addition to providing charity care. Commissioner Boyle.
No, I'm curious because not just for this application, but for others, there's always the discussion of charity care. And what happens then when they say they agree to the 2% and they go over a 2%, not necessarily this application, but any other, that you have a situation where, gee, we've given out all the charity care that we agreed to or could afford, but there's a need in the community. Does that come up with the commission at all?
So that the scenario you're describing, I want to be sure I understand it, is that, let's say they're in November and they've already exceeded their commitment.
Correct.
Would they extend more later in the year? That's up to the facility. I don't know how.
I guess it's a larger question of, is there more demand out there and is that suppressing utilization? The charity care has been met, but I'm sorry, we can't take you, and are people not coming? Do we know that it's an issue or not? It's not necessarily for this, it's just in general.
It probably is across the board. I think from our perspective, at least when I look at this sort of thing, it's much more concerning to me in the context of an acute care hospital than a rehab hospital. Not that the rehab hospital mission isn't critically important, it is, but if patients don't have access to a rehab hospital, there are other alternatives. Acute care model, if you come into a hospital with an acute condition, that's a life or death issue potentially.
I'm just curious what happens to people.
They go home.
Yeah, they don't get admitted to the rehab hospital if there's not access. And an individual rehab hospital obviously has choice at any point in time to say yes or no. And even in the context of, say, July, and they've only given out half of the charity care that they've been committed to giving for a year, they do have the option to say that, no, we've got competing bed priorities, and there's still a no based on charity care. So it's a complicated problem that gets partially solved through this mechanism, but one that we need to continue to monitor, as everybody has noted. Other questions? The motion has been made and seconded. All in favor?
Aye.
Any opposed? Guys have it. Congratulations. You have your.
Thank you very much. Executive stay.
Yes. Thank you, Kim. Agenda item number 4, the assessment of types, quality, and level of services provided at the University of Maryland Shore Medical Center in Chestertown. It's a presentation with no action item attached to it. In the last legislative session, the Maryland Healthcare Commission was tasked with assessing the types, quality, and levels of services provided at Shore Medical Center in Chestertown. MHCC has been working on this task with the Health Services Cost Review Commission and the Office of Healthcare Quality. Paul Parker, the Director for the Center of Healthcare Facilities Planning and Development, and Megan Renfrew, the Chief of Government Affairs and Special Projects, will provide an overview of the assessment findings. Annette Lindeman from LD Consulting will join Paul and Megan at the table. The second presentation will follow that examines models of rural healthcare delivery that could work in Maryland's rural communities. Paul, Megan, Annette, the floor is yours.
So I'm going to start with just describing these two projects in a little more detail. We were asked in the last session of the legislature to do an assessment of services that are provided at the University of Maryland Shore Medical Center at Chestertown. The assessment asks us to particularly look at the time period between 2015 and 2018. This is related to the point in time in which I believe that Shore acquired the hospital, Shore Health System, which is the hospital belongs to that healthcare system. And identify any services that were reduced or transferred from the medical center in Chestertown to the University of Maryland Shore Medical Center in Easton. So that is a statutorily required task that we have. We will be back next month with a complete report, but this month we're just going to do a high-level overview. It'll give you an opportunity to ask us questions that we can take into account as we're finalizing that report over the next couple of weeks. This is then directly related to a report we are developing that looks at potential options for delivery systems that could work for rural communities in Maryland with a particular focus on the Chestertown area. These models, again, should be able to be scalable to other rural communities and must work within our total cost of care model that we have in agreement with the federal government. So that's a really important feature. And again, that will be the next agenda item. We have some contractors who are wonderful who will be coming to speak to you about that. But I think it's important to know that these two pieces fit together. One is backward looking and the other is forward looking about what options are. For key dates, again, we'll be back next month with the finished reports. We've asked for an extension on the assessment report. It was supposed to be due January 1. We will have it in, assuming you all agree with it, by the end of January. So it's not a very long extension. So I do want to provide some demographic context. The hospital in Chestertown serves residents in Kent County as well as parts of Queen Anne's County predominantly. We'll talk a little bit more about that in the next slide. This is a rural area in the state, and Kent County has actually seen a population decline in the past 8 years. It's also an area with a very high percentage of residents over age 65. So compared to the state as a whole and to other areas in the state, it has a proportionally high number of Medicare beneficiaries is one way we could articulate that. Kent County also has more people without health insurance than some of the other regions of the state and the state as a whole, which I think is also an important feature. The median household income is lower than the state as a whole. And in Chestertown itself, the persons in poverty is higher than the state as a whole. So that gives you some context of what the community is we're looking at. Queen Anne's County looks a little bit different. Their incomes are a little higher, not quite as high a percentage of elderly residents, but sort of on the spectrum between that and the state as a whole. So now I want to talk about the hospital service area. We thought it was important to define the service area that this hospital relates to. And the way we did that was looking at the essentially 85% of discharges from the hospital and asking where did those people come from? Where do they reside? And they reside in 9 zip codes. These zip codes are in Kent County and northern Queen Anne's County. We looked at that in 2011. That's a little before the study period, but it's also before, it's after the University of Maryland acquired the Chester River Hospital, but before Shore acquired it. So it's sort of sitting in between those two events, which are important to the history of the hospital. The service area has changed over time. If we look at 2018, one of those zip codes drops out. So it goes down to 8 zip codes that generate the 85% of discharges. I do think it's important to know that the service area is not the same as market share. So this is looking at when you look at the discharges from the hospital where those people reside. It's just a different question than if you look at the people who reside in these zip codes, where do they go to the hospital, right? And so we'll talk a little bit about market share later in this presentation. Any questions about service area? Okay. So we were asked in the statute to look at three things, to look at the type of services that were provided, the volume of services that were provided, and the quality of services that are provided. The next slides will follow that structure. So we're going to start with type of services. And when we think about types of services in the hospital environment, we think of them at the highest level in 4 categories. So we think about medical, surgical, gynecological, and addiction services as one bucket. And then we think about obstetric, pediatric, and acute psychiatric services. When we look at the study period here for Chestertown, they provided medical, surgical, gynecological, and addiction services, the sort of general MSGA service bucket in 2015. They still provide that service bucket in 2018. Under the hood, there are some service categories that had very low utilization in 2015, and now utilization has disappeared. And by low, I mean 5 discharges in here. And now that's gone away. There also appears to be a smaller number, but a few service categories where utilization has gone from 0 to a positive number. I think it is important to note that the University of Maryland at Shore Medical Center did not add service categories that where the utilization disappeared at Chestertown. So it's not like straight like types of categories are moving. Okay. So that's the end of what I'm going to present for a minute. I'm going to come back at the end and wrap this up, but I'm going to pass this over to Paul. Yes.
So
I don't know how we got on 21. Oh, because the slide numbers are different than what I have in front of me. Okay.
So when we look at the medical center at Easton, it provides 2 types of acute inpatient service, MSGA services and also obstetric services. If we go back to 2010, this was also the service mix for inpatient services at Chestertown. They were providing MSGA and obstetric services, but the small number of obstetricians in that service area of Chestertown decided to stop delivering babies. They had a very small delivery volume and kind of switched their deliveries to Anne Arundel Medical Center. And so that service was discontinued. I think it was about 9 years ago. So both of these hospitals allocate a bed, literally, of their total licensed bed capacity to pediatric services, but they don't provide substantive levels of this service. No reported patient days in 2018 for patients under the age of 14. At Chestertown, only 156 patient days at Easton. As with Chestertown, at Easton, we see some changes in the diagnostic mix of MSGA patients over the study period of 2015 to 2018. Easton, just as a side note, has been authorized in the past year to actually have 3 inpatient services in the future. Acute psychiatric services within the Shore Regional Health System are currently provided at the hospital in Cambridge, which is the medical center in Dorchester. That hospital was approved to convert to a freestanding medical facility. We anticipate that's going to happen in 2021. And at that point, Easton is authorized to create a 12-bed psychiatric unit. So at that point, it would have 3 inpatient services. So when we look at types of outpatient services, again, in 2015, and I'd say in 2018 as well, Chestertown provides an array of outpatient diagnostic and treatment services that are fairly typical of a small rural hospital. No outpatient service categories comprising the most frequently provided disappeared over this period or were added. We did see 4 service categories accounting for approximately 80% of total outpatient visits over this period. And within this group, the hospital saw a significant increase in two of these services, computed tomography, which is a diagnostic imaging service, 16.4% increase over the 3-year period, a significant decline in what are identified as drug-related visits, minus 7.4%. Changes in type of outpatient services provided, continuing with that, significant declines experienced in some frequently provided outpatient services, specifically the 3 shown there. Surgical related services, in particular, we see a fairly significant decline in use of the operating room and anesthesia services. Again, this is the way the data set categorizes outpatient services. And a big decline in electrocardiography visits. Reported outpatient clinic visits, however, saw a significant increase over that period, nearly doubling.
Oh, is that a typo in the surgical? Because it looks like an increase, not a decrease. 29.5.
It is a high typo. There should be a
Minus 29.
minus in front of that. Sorry about that.
Yeah.
So now we switch from looking at types of services to volume of inpatient services. And here's where we did see a significant change. As you can see, we looked at Chestertown, we looked at Anne Arundel and Easton, which are the 2 general hospitals that are the chief alternatives for patients who are originating from the Chestertown Hospital service area. We also looked at University of Maryland and Johns Hopkins, other Maryland hospitals for context. So you see this decline at Chestertown, and in terms of their service area between 2015 and 2018, that translates into a decline from 41% market share to 31% market share. We see a slight uptick in market share at Anne Arundel, and a pretty significant uptick for Easton. So within the service area, we're seeing declining use for inpatient hospital services. That's typical. We see that across the state broadly. 445 fewer discharges from any hospital for patients in that 9 zip code area. So the pie is shrinking, if you will, but within the shrinking pie, we do see Anne Arundel and Hospital in Easton picking up market share in that service area. So inpatient volume at Chestertown declined at an average annual rate of 50%, for patient days, 12% discharges. And then we have general hospital acute care licensure that follows this census trend. So we saw a decline in licensed acute care beds, drop from 30 to 12 beds between FY 2015 and FY 2020. We see that Medicare pays for 75% of inpatient care at Chestertown, which is higher than we see in the state. For the state average, Medicaid pays for 10%, also higher than the state average. About 90% of admissions originate in the emergency department. So the patients that are admitted at Chestertown primarily first present themselves at the emergency department. That's quite a bit higher than what we see in most hospitals. Approximately 25% of discharges are to skilled nursing facilities. 8% are to home health agency services. Again, as Megan noted, this is a service area population that is older than what we see in most areas of the state. And the Chestertown average length of stay was pretty short, 3.9 days. Outpatient volume has not declined significantly over the 3-year period. period, about a 1% average annual rate of decline. Medicare pays for just under 50% of outpatient service at the hospital. Medicaid pays for 20%. Approximately a third of total outpatient visits are emergency department visits. So those are obviously emergency department visits that do not result in admission to the hospital. Quality of care, this is a table that looks at some quality of care measures, readmissions, and prevention quality indicator admissions. These are admissions that based on the patient's conditions are flagged as admissions that could have been avoided if care had been administered on an outpatient basis, perhaps on a more timely basis. So we've seen some good progress here over the 3-year period, decline of about 15%. And readmissions, that's when a patient is readmitted to a hospital within 30 days following discharge. And then you see a 32% decline in PQI admissions. Financial performance over this period, net revenue actually increased. So net would be gross revenue billed, gross billings minus contractual adjustments, bad debt, other adjustments to revenue. Increased at an average annual rate of almost 3% over the 3-year period. Gross patient service revenue declined, so that's the actual billings. And that was at a similar rate of decline, $64 million in gross revenue in 2015, $59 million in 2018.
Can you elaborate on the difference between the net revenue increase and the gross patient revenue declining? I'm not sure I understand.
Well, I think what that would indicate is that adjustments to revenue declined at a faster rate than gross revenue. So that's what allowed the net revenue to go up while gross revenue went down. So contractual adjustments, I think there was significant decline, and that's shaking your head here.
Yeah, so it's worth noting that for 2015, Shore Regional Health, they had a $10 million contractual adjustment to the gross patient revenue, basically bringing it down $10 million, which is very high compared to other years, which is usually around $3 million. We asked them about why was the 2015 so high, and basically they came back and said that they identified an overpayment that was throughout the course of about 3 or 4 years that they then had to book in 2015, and that's why that was so high. So essentially, had they not decreased their revenue with that payback to CMS, we would see a decrease from 15 to 18 in the net revenue. Essentially about $6 million is what they said.
The hospital was able to reduce its operating expenses at a pretty good pace, average decline of 2% over the period. The use of global budgeted revenue, the payment model in Maryland, means that at least over the short term, rates per discharge or visit go up when volume declines. So I think it's fair to say that in general, Chestertown's declining volume has translated into higher charges, making it a relatively high charge hospital. This obviously reduces its appeal for payers. The global budget revenue can delay the fiscal impact of good volume declines. I would say that it cannot eliminate the impact.
Before you change, just want to make sure I understand. So go back to the part you have there in bold. GBR can delay fiscal impact. Keep going back there a little bit more, plain language. I'm trying to figure out, is this good? Is this bad? What are you saying?
The short term, because we have essentially a revenue target that the hospital is trying to hit on the global budget that's set for it, if its volume declines in a way that was not anticipated when that global budget revenue target was hit. That means that its charges per case are going to have to go up in order for it to prevent it from really falling far below the revenue target.
So reducing unnecessary readmissions is a good or bad thing?
So this is good volume declines. That would be considered bad volume declines in the
Bad volume
HSCRC
declines
line.
are a good thing.
That's right.
Reducing readmissions, yes, is a good thing.
Reducing, yeah,
So this is good volume declines.
right. So scheduled elective surgery, for example. So I use hip replacements as the classic example of this. So a population needs a certain number of hip replacements. If the hospital decides not to do as many hip replacements in a given period, it's still going to get paid for them under GBR for a while. There'll be two impacts. One is the average cost per other things in the hospital. For everything in the hospital will go up because they decrease the number of those. But over time, the HSCRC will take those dollars away.
How long does it take to get back out?
Well, 50% of it comes out the following year.
So when they make those decisions, I'm going to do fewer, in your example, hip replacements. That's a business decision they're making.
Sometimes it's a business decision. Sometimes you lose a physician in the community.
Okay.
Sometimes there'll be competition who comes in and steals the hip replacements away to someplace else. And sometimes it's an active business decision. We've looked in Maryland. We haven't found active business decisions around that yet.
Okay.
But it's a risk in a GBR model.
So just saying that there's attribution and reasons that are always apparent, in the bullet items. And so that complexity, I think, that would really benefit understanding.
Yes. So demand for inpatient care, as we've reviewed, has been dropping at this hospital. Some of that is good, because some of that is fewer readmissions, for example, fewer PQI admissions. But some of it is just other hospitals are increasing their
I
market
was
share.
going to say, is it a shift in volume to other hospitals?
That's what I was trying to understand.
Yes, I
Why
mean-
why
Yes.
are they using the East
So these
End,
other
for instance?
hospitals getting these volumes, eventually they're going to get the revenue back from these volumes. How long does it take for them to get the revenue back?
In the other hospital?
So the other hospital, we're shifting those volumes to another hospital.
Right.
Right? And eventually, their volumes are going up, so they're going to be on pressure with their GBR because they have more volumes than their GBR can handle. They're going to have to get adjustment.
And the
on GBR.
recalculation, yeah.
So my issue is that
Yeah. Do
it's
they
the
get,
same-
do they
it's
get
the
bumped
same
up?
dollars, I'm okay with
So
it. But if
there's a,
50% in the first,
it takes a year, it takes a fiscal year to occur.
close
And
to
there's a
the-
market shift calculation that the HSCRC does to look at the degree to which there was a market shift that occurred. When you can demonstrate that a market shift occurred, 50% of the dollars come out from the hospital that lost it, 50% go in to the hospital that got it. But that assumes that the actual variable cost of the case was 50%.
Right.
If the actual variable cost was more than that, then the hospital that lost the volume wins.
Right.
Because they lost the cost and didn't lose all the revenue, and the hospital that gained it loses. And if the reverse is true, then there are winners and losers.
But some of these declines look consistent with what you started with the population decline overall in the area. So, I mean, we would expect that, if your population goes down by 15, we don't expect you to hold your market share, et cetera, et cetera. Okay.
Even if they had held market share, they would have seen declines in demand for their services because demand has shrunk in Asia.
And does that lead to a GBR adjustment?
Eventually.
Hope so.
Eventually meaning the next fiscal year or X number of years later?
When you lose volume over time outside the quarter, you lose the GBR. But in order for somebody else to get it, they have to show a market share.
And it probably needs to be emphasized that HSCRC has been very cautious about reducing the GBR at Chestertown because of some of the things you're seeing right now. So while they could have been abrupt, they've been somewhat slower to act than they might have been.
Does the other 50% go away in the following year?
No. Not yet.
Interesting.
There are corridors around the state.
Yeah.
So if you, in other words, if you exceed your charge corridors by 5% in one direction or another, you put on watch. If you exceed by 10%, they can actually claw back some of the volume, some of the dollars out of market shift. It's my understanding there's no.
Well, the only other question, I mean, you talked about financials. Do their bottom line change? How'd their bottom line change? Making money, losing money, break even?
The bottom line improved
Bottom line.
over this period.
Not the one.
Yeah, there's bad news coming.
Okay, I'm just trying to.
But that was the artifact of the payback to CMS for Oakland,
To some extent, yes.
To make a point further on, I think I should wait for this, but the residents of the informant interview findings, the residents of the service area are bypassing Chestertown.
So I'm going to hold that for the next, so this slide deck, that slide particularly actually relates to the next presentation. So if
Because
you're
that
okay.
comes down to why is all this happening? Is there any reason to think it can be turned around?
Yeah, so this slide deck, we're going to focus on the quantitative data, and then we'll get to the interviews in the next presentation. So I'm going to skip ahead just to summarize what we've been talking about today. So again, as we've noted, the patient care services have not changed fundamentally. This is a small medical surgical acute care hospital that's seen changes in volume. The demand for inpatient services have declined over the past few years, including, and that this rate is more rapid than the decline we've seen in Maryland as a whole, although inpatient demand is declining overall. The outpatient volume's relatively unchanged, just a small change in volume there. The shrinking service area, the service area has both shrunk and market share is shifting so that people are using those two other hospitals to the extent that they are still seeking inpatient care. And possibly also, we didn't talk about this, but possibly also using hospitals over the Delaware border. That's harder for us to see in the data sets we have, but that's a distinct possibility. And elective admissions have declined in the hospital, and so that relates to that 90% coming from the ED figure. And while, and so going back to that market share, we have seen Easton pick up some of the service area, the market share from the Chestertown service area. Another thing that we haven't talked about so far, but I think it's relevant to the financials we were just discussing, Shore Health has made some decisions to regionalize administrative functions and some clinical services that we don't think that's unusual or inconsistent with the state of the market environment and sort of how health systems work. But that does mean that some folks in Chestertown feel like they're disconnected from system leadership. We're hearing articulation of concerns around that. So that's the summary. I am going to turn back to a slide that's just going to transition us to the next presentation. We're not going to cover all the slides in this deck today, but there are some background slides that give some more examples of how the GBR works. If anyone has questions about that, we're happy to answer them. But for right now, I'm just going to say we are going to turn to the models report next. It will have additional data analysis, findings from the interviews, so that's what's there, and then some talk about the models. I also want to thank LD Consulting. So Annette Lindemann is here at the table with us. They crunched all the numbers, which is very important to this, and when you see the final report next month, you will see that the volume of numbers they crunched is very high. This is just the top of the surface, and that's been a tremendous help to us, so we really appreciate their help. So I want to open up the floor for questions if anyone has questions.
Commissioner Jordan.
Mine's more of a process. Why did we do this? Spend all this time and energy and have a great staff report?
Because the legislature told us to.
Legislate somebody or the whole
The
legislature?
legislature voted on it, the governor signed it, it's the law, and we're doing it.
So it comes to us, and so we have to react to it.
We have to produce the report for the legislature. So what the legislature asks for is the
We
report.
send it back to them.
We send it back to the legislature, and it's due at the end of the month, end of January. It was due January 1st. We asked for an extension. We got it.
Okay, and so we're going to approve it, so we own it, so to speak. Just sending.
The
Next month.
legislature
Next
can
month.
commission
This
the,
enormous amount of time and energy to do something for the legislature, just to send it back.
that's what they asked us to do. Yes, that's correct.
And the idea is that it then informs them. So there was a bill on this hospital last year that sought to change the delivery system and get the state more involved. And that turned into a study. That's a frequent thing that happens with bills in the legislature. This is the study. So then if the bill comes back.
Did you say you're coming back next month to do this again?
Well, this is a preliminary
There's-
report. We will have a final report next month.
You'll have
Yeah.
a report.
It gives us a little bit more time to digest it and prepare questions for next month. The report will theoretically inform legislative decisions regarding additional legislative action. We should also understand this because this affects decisions that we make regarding things like certificate of need and health policy throughout the state at our level. So we should understand the report and the situation with regard to rural health from the standpoint of making decisions about that. But the primary purpose of this was to potentially inform decisions that the legislature would make regarding rural health in the state of Maryland. And they want our input. They want to know what we think of all this. And through staff, we commission the report and we come back and comment on it and send them a report.
So this is something real as opposed to what most of us would suspect is just a political issue for across the bridge. For whatever reasons, we just serve basically, right?
Yeah, the degree to which
This has nothing to do with rural health or anything else. Come on, we know what this is.
Well,
I'm not gonna comment on that.
No, but I'm not asking you to comment, but I'm just trying to understand, as a new commissioner, we sit here, we spend 45 minutes hearing a wonderful presentation. And then next month, we're going to hear, and.
We'll not hear the same thing over
Sign
again.
off and we send it back to them, and that's the way it works, huh?
Well, it's
Yeah,
not,
but-
it's not unreasonable though for them to ask to tap into the expertise, the research expertise of our staff. And because the staff produces it, we review it before it goes on. But if you're sort of you're hitting this political, if you're being heavily lobbied and you're getting anecdotes from one side and the other, it's not irrational to say, can I have some outside experts who I trust take a look at this and come back to us with, what is really going on here? So that seems to me, I'm comfortable with that being within our portfolio. And not that we have much choice, but it doesn't bother me to spend 45 minutes kind of making sure that T's are crossed, I's are dotted, all the questions have been answered.
So as new commissioners, I know there was some history for this hospital prior to this year or so. Can we kind of go back on what sort of happened at this hospital? Has there been some issues where they wanted to close the hospital?
Ben, do you want
I mean,
to comment on that history?
I think part of the problem is
Probably not appropriate
the
for me
newer
to-
commissioners don't understand a little bit of history maybe behind this hospital, what has happened. So we
No, I personally do.
Okay.
Yes, so, yeah, I think the history of the Healthcare Commission's involvement with Chestertown can take considerable time. What I want to say though, first to Commissioner Jordan's question is that this hospital is going to come back to you in the future months in a couple of different ways. You're going to hear these reports. There is also before the commission request to relocate the psychiatric beds that you previously approved to move to Easton. Shore Health is now proposing to move those to Chestertown. So even if this was not a request from the legislature to provide outside and independent assessments of what happened, this background is useful. It fits well in the back of your head for issues that are going to come before you in the months ahead. I don't want to say any more about that right now, but in terms of the chair's question, what happened? There was a two-step process that occurred. Chestertown was first acquired by the University of Maryland Health System in the 2008 period, and then was merged with Shore Health, which consisted of Easton and Dorchester in a separate acquisition in about 2011. I may have the dates.
We'll have the dates in the report. We have
But
for that.
at the same time, after these acquisitions, there was considerable discussion consistent with what's happening across the country. How can we regionalize healthcare in rural areas in particular? And a plan was put forth by Shore Health leadership, which they outlined what they plan to do on the mid-shore, which includes the five counties of Kent, Dorchester, Talbot, Queen Anne's, and Caroline counties. And it entailed building a new hospital in Talbot County and consolidating services, inpatient services in that jurisdiction. It was at that point, 2015, discussion on in both Dorchester Memorial, the hospital there, and Chestertown, that those hospitals be closed and converted to freestanding medical facilities. You met that. There was general support for that idea in Cambridge, Dorchester, and but staunch resistance in Chestertown, with residents pointing to the significant distances that you would have to travel to Talbot County, Easton for services. Shore Health rethought that idea in part on their own initiative, in part due to the strong political opposition. A legislative study was directed for MHCC to start. We convened a rural health collaborative rural health work group. Some of our contractor friends who were engaged in that process, a set of recommendations for broadly for moving rural health delivery forward across the state were put forward. Some of those are now being implemented, and we thought largely that our work was done, but the declines in Chestertown have continued. It's my observation that it's not that that the hospital there is becoming smaller. It's the rate of decline in that facility. Megan pointed out that over the period between 15 and 20, the number of licensed beds has dropped rather precipitously from I think 32 to 12, and concerns continue to exist. The legislature respects the commission's diligence in this area and independence, and it's central to our planning functions. In any case, thus we're here. And it's not Chestertown is simply the parakeet in the coal mine of broad challenges for rural communities across the country. So I think one of the only thing I would label us is we are not a rural state by most measures. And so we haven't had to face these challenges directly. The old hospital rate system protected everyone. You didn't ever hear of hospital closures in Maryland until recently, and we now have to address those challenges because GBR is very effective. Everyone is envious across the country that they don't have this model for rural hospitals, but it doesn't insulate us completely. And we got to think creatively to come up with some of these solutions. It's not necessarily just adding capacity, however.
Yeah, understand the politics of this. Obviously I come from a very rural area, and hospitals are kind of, dare say, like high schools. They're centers and hubs of employment and services for the greater community. So when I lived through the consolidation of the hospitals in Western Maryland, very emotional for the community, lots of stakeholders, which brings a lot of political heat to bear. So I suspect, well, obviously that's what's going on here. And then, we are a more urban state, if you will, but we still deal with Eastern Shore in the 3 counties of Western Maryland that are, extremely rural, and they deal with those types of issues. So, quite frankly, then with the governor being of the persuasion Republican with lots of rural support, I'm sure he's cognizant of what's going on in those areas because those folks come out in large numbers for him. And it is a challenge, I would have to say, to continue to, and Western Maryland's going through it again with the merger with UMPC. And, it's flaring up again. Maybe not quite as much as the consolidation of the Memorial and Sacred Heart hospitals in the 1990s, but politics are coming to play very quickly there, so I can see where they come to play very quickly as well. So probably good that such attention is being paid.
So consistent with my history of this meeting of making helpful suggestions, it would help me, I think, as well as Commissioner Doran and others, if when we had the presentations, a bullet or two at the beginning, this is a legislative mandated report. This is a report because we gave a grant. It doesn't have to be a lot of history, but I think we generally do have that in our presentations. But that much to frame the reference of why we're seeing that would be a good, consistent practice to always have. And like I said, I think 90% of the things do have that.
That was in my opening comment.
Oh, I'm sorry. I didn't realize I had to listen to your opening comments. In the future,
Always the way, I know it's hard.
As vice chair, more carefully than the rest of us.
And I'm in suspense until the meeting. I don't know why I'm reading.
Right, I did hear that. So mine was more of trying to understand the process that.
Why that made sense.
What we just automatically have to do and spend enormous amount of time and staff and whatever. I guess the issue for me, and Miles will bring it out right now, is that if all this is sent to us, and as board members, there's an expectation we read it. Okay? I question then why it has to be reread to us in total, sitting around the table, as opposed to saying, here's 3 highlights. You've had this report. Do you have any questions about it?
There's a balance there between reading the entire report to us and between just asking us to vote on things without a presentation attached to them. I've leaned in the direction that you just described very heavily, that we spend too much time having things read to us that we should have read ourselves and been prepared for. There is
just a balance, I guess.
Especially
on issues where we're not.
I'm empathizing with the point. I'm empathizing with the point you're trying to make. I agree with you. But it's a hard balance. It is between, and some of it, like in this situation, involves thought that is currently being developed. So the comments that we're making around the table, I think, help inform the final report. These are questions that I think many legislators will have when they read the report, the questions that we're raising now. So this is a valuable time to have that input. But to Commissioner Dorton's point, I think that we do get a lot of things read to us. And I think it's fair to expect that the commissioners have read the materials in advance. I can tell from this room right now that that's the case, that most people in this room have actually read all the materials that they were sent. Having been at this table for a little while, for a few years, I can tell you that that's not always been the case, and I applaud the commissioners for the preparation that went into this meeting.
Just briefly, having been here a while, resonate with you. It's also an extremely important learning opportunity as a group versus when we're reading it separately. And there will be times that we're going to disagree. That's when you see the value of what we're doing here. This is a public forum. Right now, this is open to the public. There could be comments here we've never even thought about that could come up. This is the transparency that gives us the credibility that the legislature has. So I slogged through it. I learned a lot. And when we have consensus, it's not as much dynamic, but there will be times where we may not agree. And that's when it gets exciting.
Now, one last point, Chip, just to point out, I think that when you read these materials, having been former CEO of Anne Arundel Medical Center, your fund of knowledge with regard to this entire subject is going to be a little higher than some of the others around the table who might need a little bit more explanation. Thank you.
All right, thank you.
On to rural health. So now we turn towards the future of rural health delivery. MHCC is contracted with the Walsh Center for Rural Health Analysis at the NORC at the University of Chicago to study the needs of Kent County and Upper Queen Anne's County communities and identify potential models for healthcare delivery that could meet the needs of those communities, preserve access to inpatient care, and work with the total cost of care model framework for hospital financing. Today, we're joined by Dr. Alana Knudsen, co-director of the Walsh Center, who will present initial findings and the outlines of potential models. The team from the Walsh Center will return next month with a final report, but this is our opportunity to offer input while the report is still in development.
Well, thank you very much. And I'm just going to introduce you to our organization in case you do not know who NRC is. First of all, we are NRC at the University of Chicago. We are a nonprofit, nonpartisan organization that focuses on research. And in particular, we are contracted by MHCC to work with our Walsh Center for Rural Health Analysis. We are the only rural health research center here within the Beltway of Maryland and the DC area. And we have conducted these types of research for over 20 years. In fact, our first study on rural health dates back to the 50s. So we are one of the oldest rural health research centers in the country. So with that, our team is also located in Bethesda, so we are local, and we have made many trips to Chestertown in the past. And as Ben had indicated, we were also contracted to work on the rural health work group that met for the last 2 years that concluded in November of 2017. So we know the issues on the Eastern Shore very well, and we work across the country addressing different types of rural health issues affecting healthcare and public health, and looking at the health and well-being of rural communities. And in fact, we are also evaluating right now the Vermont ACO model, as well as the new Pennsylvania Global Budget model that is focused solely on rural hospitals in Pennsylvania. So we have a really good idea of what is happening on the national level, and we get our boots on the ground and we get to a lot of these rural communities. So with that, let me share with you what we have learned. As we have discussed, we are looking at the healthcare needs of the residents in Kent and Upper Queen Anne's County. We are also looking at these needs through the lens of the total cost of care demonstration to ensure that anything that we are recommending aligns with what is already set forth in that demonstration. Just to share what we have done thus far as part of our work for MHCC, we've done an extensive review of the documents, not only of MHCC, but also of HSCRC, so that we can ensure that what we're looking at, again, aligns with the total cost of care. We've also conducted a number of key informant interviews in Chestertown, as well as on the phone with not only business leaders, education leaders, community leaders, providers, and also other folks that are interested in understanding how that Chestertown hospital and the healthcare system harmonizes with one another. We have also done a review of the data that you were just presented from LD Consulting, as well as conducted a systematic scan of what is going on nationally. Again, we have a number of research and evaluation projects that are looking at new and evolving models across the country, and we have taken that background information to help provide this recommendation for your consideration going forward. As such, the most important information that we looked at really pertains to inpatient utilization. And again, because of our work with so many rural hospitals, the payer array in Chestertown is very similar to what we see in other rural hospitals, where you see the majority of payment coming from Medicare, with balance coming from Medicaid and commercial pay. And for Chestertown, we're looking at 85%. That's a very high amount. Likely you see where the discharges are going. You're seeing 1 out of 4 going to skilled nursing facilities and almost 1 out of 10 going to home health. Again, very comparable to what we see when we're looking at a high proportion of older adults who are being hospitalized in this type of a hospital. We are also looking at an average length of stay of 3.9, which again is very similar to what we see in other rural communities, and the average daily census is 10. And the majority of rural hospitals across the country have 25 or fewer beds, and the average daily census is 7. So again, we're looking very much at what we see in other rural facilities. Likewise, we see high utilization of Medicare and Medicaid on the outpatient side, as well as about 1/3 of the visits coming in through the ED. As I said, we talked to a number of people in the Chestertown area, and it is clear the residents told us they are bypassing Chestertown Hospital. They indicated that transportation is a challenge. Transportation is a challenge in every rural community that we visit. It is not unique to Chestertown. However, what we heard clearly time and time again was that the residents and the leaders of the community felt that there was very poor communication and there was considerable mistrust of the current hospital system. And that is not something that we always hear when we go to rural communities. As we said, the population is older and growing. And we also learned that in Chestertown, it's important for them to continue to be a destination community for retirees. As mentioned, 1 in 4 people are over the age of 65 in that community, and they've built up a number of opportunities for older adults to retire. And part of that economic development piece is also linked to having inpatient care available locally. So that was also an important consideration. Likewise, the issue of it being an economic driver for attracting employment, that was also noted as an important consideration. As was mentioned, it also employs a number of people in that community, which is a great consideration as well. I will add there was a mixed response on the sufficiency of the availability of primary care providers. And in rural communities, a robust primary care is foundational to the healthcare delivery system. So that is an issue to consider. And we were also very surprised, frankly, at the alignment between the comments that we heard from the hospital leadership and providers in the community with the residents of the community, recognizing that healthcare is changing and the healthcare of yesterday is not the healthcare of today or tomorrow. And there was a lot more alignment in the understanding of what is realistic for the delivery of care in that community. However, the people that we interviewed as residents were very committed to making sure that there was still an inpatient opportunity. Yes.
Excuse me, I just have one question. So they're bypassing the hospital.
Some are.
And transportation is a challenge, but the other statistics we saw, more are going to Easton, for instance, and Arundel, and aren't they further? So that isn't just transportation.
No, it isn't. And that's where I also said that there's been poor communication. And so I think some of this people are not clear always what services are available locally. And so there may be services still available locally, but they assume that they're now only available in other communities. We heard that more than one time.
And this may have answered the question I was about to ask about what they meant by community mistrust. Is it a mistrust of the quality of the services or part of that misperception as to what was available?
I think mistrust, and I think this came up in some of the former legislation that had been passed, where there was a feeling that the hospital leadership at Easton was looking at minimizing the availability of services so that those could be downsized. Also, I think there's just a mistrust understanding whether or not the needs of Chestertown are being addressed. Is it being addressed as a region, or is the community of Chestertown really being heard as rural residents and the service needs that they have really being brought to the forefront? I will tell you that when you go to rural communities, hospitals, and we know that in a lot of our urban communities, hospitals are often the catalyst for a lot of change and energy in those communities. And I think there is a perception that the leadership, the locus of control, is no longer in Chestertown. It is in Easton. It is away from them, and they do not have the same kind of input that they have had in the past.
Yes.
So I'm so glad that you elaborated on the sense of the community not losing agency or feeling that they're losing agency. It's unfortunate but true that hospitals are, civic and community role. So with my question, this is a decision to go to bypass gesture is a preference of the patient, or is it driven by other factors like if some payers have expectations that hospitals meet certain quality standards, and if they don't meet those standards, they may send them to someplace else. How much, if any, of that might be going on in terms of, just in terms of, again, is the driver the patient saying, I'm deciding, Miss Smith's deciding I'm going to go to Easton, or Miss Smith has to go to Easton because the payer says she has to go to Easton? That's different.
Yeah.
Or Miss Smith goes to Easton because that's where her doctor is now. That's quite different than the Chester Hospital somehow losing confidence of its community. There are other outside forces driving people away. Do you have any information on that?
Well, other forces that also contribute to these decisions are also providers. So when you have providers, and we see this in other rural communities as well across the country, when you have providers, for example, specialty providers that come into a community and provide services, often then the people will leave. For example, there's no thoracic surgery happening. And if you look at the level of acuity that is now being served in our communities or in our hospitals, you will see that the level of acuity continues to increase. So more of those conditions are managed at home or in an outpatient basis. And so if you have somebody who, for example, is getting cardiology care through a specialist, either coming to Chestertown or through an Easton connection, they're going to go to Easton for that service because that cardiologist is providing services in that community.
So that's a little nuanced, but like really, really, really important.
I agree. That's answering what I was trying to understand.
Yeah, stay right there. I'm going to throw the ball to you, but that needs to be lifted up in some of this narrative. It's not just a patient making a decision, or outside forces driving some of this.
Well, and I can tell you in some other communities as well, it can also be decisions made by family members, depending upon where family members live and work. And that can also be a consideration in that. And that's why it's really difficult. That's why we need these kinds of interviews, because claims data provides so much information, but we do not know always what those underlying contributing factors are. And I want to be very clear. We interviewed a set number of people. We did not interview over 20 people. We didn't have the time or the resources to be able to have large surveys in Chestertown. But of the thought leaders that we did interview, this was the information that we were able to glean.
But if you interviewed 20 people in Chestertown, that's most of them.
You gotta be careful.
Commissioner Boyle, do you have another question?
Okay. Then with that, let me just share this. And I want to also point out, this slide is not exactly a continuum. We're sharing some optional models, two of which are related to hospitals, and the other one is an additional consideration for that community, for an aging and wellness center of excellence. And I'm going to explain each of them, but I just want to make sure this is not a continuum quite as this has been arrayed here. So let's go on to some cross-cutting issues that we heard. As I said, with regard to the issues of perception, based on our experiences in other rural communities, enhancing community engagement, specifically conducting a Chestertown community health needs assessment to understand what the needs are of the residents and the people that that hospital serves would be an important activity to undertake, to really understand what needs to be right size and what types of services are needed by the community and what is the community willing to use. Those are two very important considerations. Likewise, it's important to look at health literacy. And I say that from the standpoint, again, that many of our residents that we talked to did not fully know what array of services were available. They did not feel that they had the information they needed to make an informed decision as a patient. The third recommendation that we heard that could be a consideration to help in this arena is to implement a mobile integrated health program. This is available in Queens Anne County. I know there are other counties that have this implemented, but where you have community, more or less community paramedicine, where you have paramedics going into the home, given the high proportion of older adults. Again, this doesn't necessarily fall under the global budget, but the hospital can serve also as a catalyst, as leadership in that community to be able to help identify other resources that can be leveraged to better help support the health and well-being of the residents in that community. Likewise, looking at the adequacy of the volunteer emergency medical services, how many of you have been across the Bay Bridge lately? What is the biggest challenge we have there for the next 3 years?
Bridging it back.
Yes, there's a lot of concern within the community by the residents about how adequate is a volunteer EMT system if they have to take people across the bridge and there are wait times of 2 to 3 hours. How many volunteers are going to be able to continue to do that over time to be able to serve the needs of that community? Likewise, we also heard the challenges of not having adequate non-emergency transportation. The one taxi service, Keyline Taxi, is going to be leaving Chestertown, and United Way now has a study underway to look at transportation options. But again, there are other resources that could be leveraged that could help that Chestertown health community strengthen. There are also opportunities to optimize the rural workforce training in that community. As many of you may know, the University of Maryland School of Medicine received a $750,000 training grant from HRSA, the Health Services and Resources Administration, to enhance the training for rural providers of the Eastern Shore. Chestertown would be a fantastic place to bring residents and medical students who are interested in having a rural experience. And frankly, with the excess rooms that are in that facility, they could even have apartments put together on a short-term basis. And again, it's about thinking outside of the box and how can you invigorate a community that has a lot of assets. And I just want to really focus. These cross-cutting considerations are also about the strength and assets of the community. It's not all about needs and deficits. There are many assets in this community, and the residents were really clear that they are about wanting to have services that are available, that have a level of excellence in their community, but that are appropriate for the needs of their community. Likewise, expanding broadband, there are a number of FCC and USDA types of grants that are available that can enhance that. If you drive down the street in Chestertown, as we have done, even on calls with Ben, we can't talk to him because he drops off because the cell service is so poor. Well, there's a lot of services now moving into the home. They need better broadband if they are going to be able to leverage the technology options that are out there, particularly if they want to continue serving that older adult population. So with that, are there any questions on these cross-cutting considerations?
So one, if I'm correct, one thought I have looking at this is when we get started in these discussions, we're often the tone of so sad for the hospital, we need to save the hospital. It looks to me, when I see a list like this, I see a building a post-hospital center health center system. The way to get help, that we can't keep all the hospitals we have in these rural areas. Every time you see healthcare consultants, they just write off community hospitals basically and say, what's the next thing after that? That what you're talking about here is building a post-hospital center health system in Chestertown. Is that right?
Well, actually, what we believe, based on the interviews that we had and our work with the commission, is that it would be important to think about what kind of inpatient. The residents of the community were really opposed to having only observation beds available. And if you look at how healthcare services are delivered in rural communities, the number 1 and 2 admissions for most rural hospitals, community-acquired pneumonia and congestive heart failure. Those are things that those older adults want to stay local for, and frankly, rural hospitals do a great job. They have very good quality in providing care. Is Chestertown a thoracic hospital surgical center? No, and it never will be. But what can the inpatient services, are there inpatient services that can be arrayed to meet the current needs, recognizing that it can't be all things to all people?
Yes.
Yeah, just very quickly. There's a university there in Chestertown.
There is Washington University.
Now, it hasn't come up.
College, Luke's College.
That's all right, it hasn't come up, but my point is, did it emerge as a partner, resource, or anything in your interviews?
We had an opportunity to talk to the leadership. And of course, they greatly value having access to an emergency department and a hospital. When young adults are in that community, they often don't need healthcare. But when they do, it's usually because there's some kind of a trauma, a broken leg, or some kind of accident, and they very much appreciate having that access to care. They also have an infirmary or a nurse practitioner that provides care, so they have some on-site as well. But to your point, they also have students there that could also benefit even more from having opportunities of looking intergenerational. What kind of way can we provide in rural Maryland opportunities to have an experience that may also serve as a pipeline to bring those students back when they finish their training, wherever it may be.
Again, just to piggyback off of your point, this is actually creating a pro-health point of view or community within this community versus a responsive health center, which what most people are looking at the hospital as is when I need surgery, I go there. But this is a holistic approach to health versus a reactive approach to health.
And also building the health of the future. What is the health of the future going to look like if you don't have broadband and you have over 1 out of 4 adults that are older? What is that going to look like? We have visited communities, for example, that do home health with patient monitoring at home. They have all Bluetooth-enabled monitors, and then they have a dashboard, and then they can go out and be able to identify those that are in the most urgent need of support at the right time, because you don't have an endless supply of home health providers. So you need to target where those highest needs are, so you keep them out of the ED and keep them healthy. But you need somebody to be able to serve as that catalyst to make this happen. A convener, you need a convener to do that.
You keep using the term broadband. Are you considering that cable service, or are you looking into more wireless, 5G, et cetera?
5G, et cetera.
Okay.
All right. So with that, I just wanted to recognize that the current acute care hospital is a moving target. As we've discussed, it has gone from 32 beds down to 12, and the way that it is currently arrayed, there are concerns about its viability going into the future. That was not the charge of our work to be able to determine that, but our charge is to look at what might be a model that may work better. And so with that, I'd like to transition to a Maryland rural hospital model that could work nicely in this facility as a consideration. For those of you that are not familiar with critical access hospitals, this is a designation that was established in the Balanced Budget Act of 1997. Medicare allows for these critical access hospitals that are 25-bed hospitals. They have a 96-hour average length of stay, and they provide services on a somewhat limited service line depending on what the hospital chooses to provide, but they also ensure that there is 24/7 emergency department coverage as well as inpatient. We selected this model, and I want to be very, very clear. The critical access model at the national level has a reimbursement component that is not compatible with Maryland's total cost of care. However, the delivery side is something that has been approved by Medicare, and because Maryland requires all hospitals to be joint commission, there is a joint commission critical access hospital survey. So that would not require any changes in regulations from that aspect for Maryland's hospitals. And so with that, ICU level care does not need to be provided. It's optional. As we know, ICUs require a considerable amount of resources to maintain that level of service. The majority of rural hospitals in the country that are critical access hospitals do not have ICUs. Outpatients, specialty services, and surgery are available in these. And what's really important for the critical access hospital model is that you have very defined transfer protocols and transportation available so that when patients need a higher level of acute care, they can get those patients to the appropriate facility in a timely manner. And again, that ties back to availability of the emergency medical services in the community. There's also a number of telehealth components that can be added to a critical access hospital to also enhance, such as tele-emergency, telepharmacy. You can connect to telecardiology. You can array a whole group of different services so that if you don't have those specialty services local, when you have an issue that arises, you can be able to get those services in a timely way. Given the University of Maryland's connection, not only do they have that on shore with Easton, but you also have the Baltimore campus where you have a lot of experts as well as other renowned facilities in this area. The most important piece of a community critical access hospital is that it meets community needs. And we know that there have been a number of rural hospitals that have closed across the country, and the successful components of those hospitals that remain are those that are able to adapt to the needs and serve the needs of the communities in which they're located. And in order to better accomplish that, and given the experience of that community over time, we also recommend a consideration to include an advisory board that is comprised of a majority of patients so that that local voice is heard, because again, that was an issue that we heard over and over, that local voices are not contributing to the decisions that are made with regard to the services that are available. Are there any questions about this particular model? And again, this isn't just for Chestertown. This is a rural model that could be used in other rural communities in Maryland.
You haven't made any comments about the funding of the model. You just made comments about
the funding of the model would stay within the global budget,
within the
total, yes, within the GBR, and adhere to the total cost of care. That was our charge.
Will this have to be associated with a specific hospital system? For example, University of Maryland currently is in the community. Would it have to be connected to that, or could it be an independent organization?
Critical access hospitals are independent. They are part of organizations. For example, they may have a contracting agreement with another facility and still remain independent, but are run by another organization. A critical access hospital can also be part of a large system. For example, UPMC has a number of critical access hospitals already in New York and Pennsylvania as an example. Any other questions? All right, then let's move on to what we thought could be an added component for this community that would really also help to support the overall health and well-being. And that would be introducing the concept of an aging and wellness center of excellence. And as I mentioned, there was a lot of discussion about making sure that whatever services that are available in Chestertown are of high quality and exhibit excellence. Not only do providers want to make sure that the quality is high, but the people in the community also want to make sure that the services are appropriate and are high quality. And given the large percentage of older adults in that community, having a focus on geriatric medicine and outpatient specialty services could be an excellent way to make Chestertown, if you will, a vibrant aging and wellness center. Please know that this is not necessarily it is not part of the hospital, and there are ways to generate revenue through this type of a center. This would include looking at having a multidisciplinary team with behavioral health. You know, depression is high among our older adults. It also includes that aspect of care coordination and patient health education. And there are now Medicare opportunities through Part B, chronic care management and transition care management, which could be incorporated into these types of service arrays. Again, using telehealth for outpatient specialty services, so older adults do not have to travel, and they could get that care more frequently. As well as I mentioned, remote patient monitoring could be part of this concept, as well as having an enhanced focus on nurse education and gerontology. The nurses at Chestertown just received a Magnet Award for their excellence in nursing. This could build upon that. And likewise, having an advisory board, once again, of patients in the community that are a majority that participate in helping to make decisions about what services are most important. And we have been to different areas in the country where they are implementing these types of services. 3 weeks ago, I was in a community of 2,500 people in Dayton, Washington, where they are bringing in acupuncture and massage. Now, this is not part of the hospital, but this is part of, if you're looking at how part of this hospital could perhaps be rearrayed to serve other needs than what it does right now. We've also seen some rural communities take charge and serve adult daycare, as well as provide palliative and hospice care within these types of centers. So there are a number of different elements out there that could be part and parcel to this center.
Aside from Dayton, Washington, there are other communities.
There are other, Truckee, California. Truckee, California.
Oh, like it sounds.
Truckee. That has a very extensive, for example, cancer center that is located there. And if any of you have been to that area, they also have a 4-star chef that the cafeteria in that hospital is a community place for people to eat. It's a gathering place. So, I mean, there are different places where they have brought these. We've got diet programs.
Locations on the East Coast.
On the East Coast, I'm trying to think on the East Coast it has. A number of these are also being developed in the West. North Dakota, Minnesota, Wisconsin, and Washington are all doing community-based palliative care using these kinds of models where they're looking at the array of different services that are offered in those communities. Maine has some interesting, and I can get you the name. I visited one of the home health centers in Maine that provided rural services. But, you know, even to your discussion before about the issue of lack of hospice care, you know, that has a lot to do with windshield time. People are not reimbursed for time behind the wheel. And the more you can leverage technology, the more you can provide services at a efficient cost.
Of the items listed, both as the critical access hospital, it's the Maryland Royal Hospital or the Aging and Wellness Center, how many of these things are things that would be that aren't being done now that would be added to it, or is it a matter of sort of labeling and defining the package so that people understand what they are doing? In other words, are these actual additions to their programs that they have, or are they more?
With regard to the Maryland Rural Hospital, they're actually operating more like a critical access hospital now without the flexibility. For example, they have on-call cardiology, they have on-call pulmonology. Under Joint Commission Critical Access Hospital, you don't need to pay for that 24/7 on-call. Those are costs that would not have to be incurred. There are other ways that they can be saving money. I know, Ben.
Yeah, and I think that that in order for this to work, we would, some specialty services that the Chestertown Shore Health is struggling to provide today to sort of fully build out what they have, we would expect that they would be eliminated. And I think that that's what everyone that's been there has heard, is that we don't expect to have a full array of services at this hospital, but there needs to be some better definition of the critical services that need to stay and probably enriched, while consensus needs to be reached on specialty care that would be nice to have, but for this model it doesn't need to be there. And it's got to fit within the total cost of care budget. I mean, partly the struggle that Chestertown faces is there's offering specialty services that are not heavily utilized, and it doesn't really work.
And I would also add too that for rural hospitals to be viable, they need a very robust primary care. And really what we're looking at with this Aging and Wellness Center of Excellence is enhancing primary care with a focus on aging and wellness. And again, because Chestertown is defining itself as a destination for retirees and really trying to array its services like that, there's a way to build upon that momentum and be able to structure a healthcare system that adequately serves the needs of the population.
Just very briefly, I really like this notion of reimagining and utilizing underutilized space in innovative, interesting ways. But the term Center of Excellence is one that's used, for example, at the NIH. It's a designation you compete for in your Center of Excellence. And there may be others. So when you use the term Center of Excellence, is it in that context of a grant mechanism or some kind of official designation, or is it just branding?
All of the above. There are opportunities. One thing that is unique to Kent County in Maryland is it is a federally designated rural county. It is eligible for rural funding. There's a federal rural health policy that provides community-based grants to rural communities to make investments and test programs. And Chestertown and Kent County qualify to submit grants for those opportunities.
The opinion leaders you interviewed, did you get a sense that they were aware of that?
No.
So there's upside opportunity.
There
It just hasn't been tapped.
There is, and I think the earlier discussion that we had today, Maryland, people think of Maryland more in an urban context, and some of these nuances about what's happening in our rural communities, this may be a really great opportunity to take advantage of outside resources and not solely depend on doing business as we have done in the past.
Thank you. All right, agenda item number 6. Annually, the staff updates and submits to the commission for approval the report on the Maryland Trauma Physician Services Fund. This report captures fiscal and policy changes during the fiscal year, implementation of those changes, and projects the solvency of the fund. Since there were changes this year that affected the Primary Adult Resource Center for Trauma, in particular, I'm going to recuse myself from this discussion and vote, and Vice Chair Sargent will take over the discussion in my absence.
So we hope that Bridget would be available. She's had a event in her family that prevents her from coming today. So I'm going to do the presentation. I want to recognize Denise Ridgely, who's staff to the Trauma Fund, who's here in the audience. Assisting me is David Sharp, who given his position as principal deputy, I think he can take this on. We'll see. Trying to gain a little bit more time. I think there's 3 or 4 slides here at the start. I'll just hit them very briefly. Formed due to a crisis in 2003, which was triggered by the closure of the trauma center in Hagerstown. The state established a fund what is clear is that it identified at that time 3 risk uncompensated care and trauma, underfunding of Medicaid patients in receiving trauma care, and what was called on the inability of hospitals to fund on-call and standby costs, which are basically availability costs that hospitals pay to physicians in a variety of environments, but typically are most challenging in trauma, which for most hospitals is not a profitable enterprise. High prestige, but not profitable. The fund was amply financed through an assessment on automobile registrations and registration renewals. So over time, going through slide 3 and 4, we've added new features to the fund as time goes on to align what revenue with the obligations in the fund. We've added additional trauma centers to make them eligible for funding. These largely are the specialty trauma centers. We've expanded funding through the establishment of equipment grants. And then in terms of, if we go to the next slide, not sure why we're so far ahead out of line here, but I guess we'll sort that out at some point, 55, we expanded then in 2016. This commission decided that because of the complexity of cases, we would pay uncompensated care and on-call at an elevated rate. We are required under the law to pay at 100% of the Medicare rate, but we have the discretion, the commission does, to raise that reimbursement level to 105% if we make that determination ourselves. If we move to slide 6, let's see if we can catch up here, David. Yeah, I think I'm there. That's where I talked about 105%. How do we do all this? We have lots of partners in this fund. And by partners, we mean organizations that support the establishment or the mechanism of the trauma fund. MIMS basically provides information on who might be eligible for the trauma and compensated care component of this. To pay uncompensated care, we want to guarantee that those patients actually were in trauma, and there's a nifty tool called the trauma registry that all trauma centers participate in. So that, in a sense, is our eligibility file. We use that to determine whether, when we get claims from hospitals, whether they are, whether those are legitimate, bona fide trauma patients. It's happened on occasion, almost always by accident, a patient is not truly designated by MIMS as a trauma patient. In those cases, we don't pay. We have a contract with CoreSource, which is basically our claims adjudicator. We have a contract with Myers and Stauffer, a CPA and audit firm that audits practices and trauma centers to ensure that payments are appropriate. We work with our Medicaid partners in reconciling Medicaid reimbursement. And lastly, we depend on the MBA to disperse the $5 per renewal or per registration fees to us. They do that on an annual basis. There's an end of year reconciliation, and they would typically transfer approximately $12 million to the commission's trauma fund that's then used to finance the various reimbursement flows that we have to make. The comptroller issues checks for, we don't issue reimbursement ourselves. We submit funding requests to the comptroller, much as some of you get tax returns. These requests then are directed to the physicians for reimbursement for uncompensated care, or to the hospitals for on-call payments for for stipends that they're paying to physicians that are on call. If we jump back one slide, just in terms of the status of the fund, quick picture of where we stand. I'll probably drill down a little bit on this. In 2020, we had an appropriation of 12.3 million. And this was appropriated to 12 million for reimbursements from the fund, and we set aside 300,000 for trauma equipment grants that are specifically awarded to the trauma centers for equipment that's typically mostly related to trauma services in those particular hospitals. We award trauma grants every other year, and we can make those trauma grants in total up to 10% of the existing surplus in the fund. So it's typically not a lot of money when you divide that among 8 trauma centers that would be eligible. One of the, as you see earlier, we made lots of changes in the fund, and partly we're doing that because we typically, the revenue source has been greater than the demands on the fund, and periodically we add additional reimbursement streams. But when we develop a significant surplus, it becomes attractive for state government to then take that surplus for other state purposes. In 2018, a significant amount of this fund balance, we had, I believe, $11 million balance, and the state took $8 million from Medicaid physician payments in 2018. We were happy to help, but it would have been ideal, I suppose, to have anticipated that. They typically do it without warning. We don't have the authority to spend in the fund beyond what is permitted under the statute, so it can build up. We have been a little bit more mindful over the last couple of years that we need to be aggressive in identifying new funding responsibilities that will keep the fund as it was directed to trauma in the trauma community, or else reduce the user fees for this particular fund, so it's more aligned with needs. The result of that reduction left us with a reserve of about $4 million at the end of 2019, and in 2019 we had expenditures of about 12 million. Anticipated revenue in 2012 was about 12.7 million. So we're doing okay in terms of balancing the fund obligations against the revenue coming in, and we want to really keep pretty much along that line, because if we build up significant surpluses, then it becomes attractive for the for state government, read the legislature and the governor to appropriate that for other legitimate purposes. Moving on to the next slide. This is just simply a rendition of who's getting on call. Not going to really emphasize this too much, except to say that I've raised periodic concerns over time about, originally the fund was equally divided among the 3 main funding obligations: on call, Medicaid underpayment, and uncompensated care. As a result of the ACA and as a result of some escalation in Medicaid payments, keep in mind that we're paying Medicaid providers net of what they get from Medicaid. When they raise those Medicaid reimbursements, the gap between what is paid under Medicare and Medicaid shrinks, so our obligations shrink. The ACA has, in a helpful way, shrunk the number of uninsured, and so what we've seen is an escalation in the fund for on-call, not because that's what's left over, but rather because on-call stipends and standby stipends, if you go to any hospital, they will tell you today that these types of subsidies to physician practices to serve those hospitals have grown as reimbursement by payers has become a bit more tight, and the needs for hospitals to financially tie their relationships to physicians have grown. Hospitals have reported higher and higher on-call on-call needs, and we've reimbursed that. What I would say is that I think we have to look carefully at this fund simply being a fund to finance physician availability cost. Keep in mind that the standby is paid for when they're not delivering care. So the fund is basically funding hospitals that don't have a lot of trauma volume. They're needed to make the system work, but they're not delivering the bulk of trauma care. That's coming from the University of Maryland Park, it's coming from Hopkins, it's coming from Prince George's, which the three of them account for about 2/3 of the overall trauma cases in the state. They don't largely get on call. They collect some standby, but the other hospitals that are important to the system are garnering the bulk of the trauma funds. If we move then to the next slide, David, uncompensated care, that offsets physicians that don't get reimbursement because they're treating a patient that's uninsured. Keep in mind that the treating hospital is covered through the rate setting system. The physician is not, so this seems a fair and equitable framework for putting everyone on the same plateau. The plus side of this is over time, that's shrunk as a result of the ACA expansion. And we've seen uncompensated care payments shrink dramatically since 2014 as a result of the ACA. We have elevated payments for uncompensated care to reflect the complexity of the cases that are treated. We now reimburse for these services at 105% of the Medicare rate. Some of you were on the commission when that happened. And here again is the distribution this would, if I took a snapshot in 2005, the distribution here would look quite similar. The volume dollars has declined significantly, but the distribution of the providers who are getting the bulk of payments would be largely the same. It's Hopkins, Prince George's, et cetera, account for the bulk of the payment, and the lower level trauma centers, as you can see, don't account for significant amounts of uncompensated care. Again, broken down, what you would see here, I don't deal with this too directly, but the number of trauma providers has actually shrunk as consolidation here has worked its way through. You can see there's individuals that are receiving trauma payments, but the bulk of it's going to large physician and system-owned practices, for example. One of the big challenges we faced is that as we moved into ACA implementation, some of the early we need step 8. But we're not voting on anything right now, so we're okay. And we do have 9, I think. So we've made some adjustments in how we pay Medicaid trauma payments. As I noted, payments have shrunk, but there's been contentions that we have not been effective in identifying all of the sources of all the Medicaid payers, specifically the MCOs. We worked with Medicaid and Hilltop and have made some adjustments in the levels of Medicaid payments over the last several years. In the Hilltop study that we requested them to conduct, they found that payments were significantly lower overall than for uncompensated care payment rules. And we tried to align those. What do I mean by that? So one example is that under Medicaid and Medicare, secondary procedures that are delivered in the course of an operation are paid at a reduced rate. Under uncompensated care rules, which we administer independently, they are paid at 100% of the Medicare rate. the trauma physicians argued that they should be paid at 100% of the reimbursement level because of the complexity of the cases. These are badly injured cases, the Medicare fee schedule that all of these systems run off of don't really take into account the complexity of an individual case. They work on the law of averages, thinking that on occasion you will have a complex procedure applying this CPT code. On other instances, it will be simpler. But if you're dealing with trauma day in, day out, all you are dealing with is complex procedures. Consequently, what we decided to do, although it's not really consistent with what Medicaid allows under federal rules, that we would use additional funds from the surplus in the trauma fund to pay Medicaid beneficiaries at 100 Medicaid physicians at 100% of the reimbursement levels that are allowable. So that took into account, in a kind of rough justice sort of way, the complexity that they're treating more difficult cases on a routine basis. We had to make those changes in an ad hoc manner. If you just go back 1 second, David, in 2018, we made those through a direct adjustment and paid physicians directly. In 2019, we paid those on an ongoing basis over the course of the year. And if you jump to the next slide, this again lists those that received Medicaid differential payments. I believe this is 2018 payments, and many of the same entities appeared in the uncompensated care quadrants. What we've broken it out here is that we calculated them differentially for the fee-for-service Medicaid population and the MCO, the Medicaid managed care populations. The bulk of those Medicaid payments, as you'll note, were made to the university physicians and Hopkins physicians, and a bit to Prince George's County physicians, which stands to reason that's where the bulk of the patient populations exist. Care is delivered generally, and in those high volume trauma centers, that's where the bulk of the Medicaid patients are as well. So this is at the end of 2019. I've covered this kind of broadly. The balance in the fund at the start of 2019 before the reduction was $11 million. You see our collections, 12. We do, through our audit endeavors, collect funds back to the board, to the trauma fund. And then our uncompensated care payments, about 1.8. Our on-call, about 8.1. The Medicaid differential, both in terms of payments and the differential payments, are shown there at about 1.25 million. And then we do make a grant to, required under law. Interestingly, the Children's National Medical Center is part of the Maryland trauma system. They take many of the severely injured children from Maryland, and they require, by statute, a $590,000 standby on-call payment. We did not issue trauma equipment grants in 2019 as we had in 2018. And then the administrative costs, which are funds that go to core source, accounted for the remainder. Overall spending, as I noted earlier, about 11.8 million. Then we had a reduction of about 8 million. This is the change in the BRFA, the Budget Reconciliation and Financing Act, which is the state squares up its funding, if you will, taking money from some, giving money to others. We were the victims of the taking money from. As I noted, $8 million was taken from us, put in the Medicaid budget for physician fees. So we ended 2019 with a balance of $3.9 million. That's the good news. We will go forward with some grants in 2020. We're not quite sure about the level, but this spells out the formula. What I would note about this as a little bit of a digression is that we've worked hand in hand with HSCRC over the years. I think one of my former colleagues, Steve Ports, is in the audience, but Steve and I worked closely to get this going over the years. And although it's not a lot of money, the trauma centers really appreciate the fact that they can get money dedicated specifically to their needs that they wouldn't otherwise have had available. We bought technical equipment, but we've also bought warming beds and striker tables and things that you would think hospitals could routinely afford. So we'll be at that again this year. If you jump to the next slide, that there was legislation passed in this past legislative session that was initiated by Shock Trauma, the primary adult resource center, that historically Shock Trauma Park had not been eligible for standby payments through the fund. They had raised concerns repeatedly and consistent with the fact that the fund had been used as a source to remove funds from the trauma system. They raised issues with the legislative leadership and got the legislative support to introduce a bill that allowed and qualified them for standby payments. Standby payments are for physicians that are actually at the hospital. They're not able to do anything else. They have to be available on immediate call to deliver care, unlike on-call, which is a physician can be at his practice delivering care, but has to commit to respond within 30 minutes. Standby means that the physician is not earning or billing for other services. They are essentially sidelined, but ready to deploy almost immediately. So they argued that like others, they should qualify for standby payments. The bill was introduced that authorized the fund to reimburse Park for its documented standby expenses for the same four categories of trauma physicians, trauma surgeons, orthopedists, neurologists, anesthesiologists that are eligible for both on-call and standby. In this case, it was standby, and we were directed to develop the guidelines for how that would be paid. And we've been working over the last several months to do so. If you want to jump to the next slide. So we had already standby hours reported by Park to the comptroller, so that it was for for the current year, a framework for calculating standby expenses. We determined that we would use the same methodology, which is built off something called Medicare reasonable cost equivalence, to set the ceilings on how much standby we would pay. That is currently used in the way that other standby hospitals are paid. The distinction is that standby for the other hospitals is built into hospital rates. For the current year, we couldn't do that after discussing this with HSCRC. It was agreed upon that we would figure out how to use the trauma fund balance to pay Park in this year with discussions ongoing on what we would do in other years. So we're using what are called the reasonable cost equivalent thresholds for each of the specialty categories to set the ceiling on what we would pay for standby. This year, we included, as HSCRC does, a adjustment for continuing medical education that would typically be thought of as a component of ongoing physician expense. And we then included the malpractice premium cost, average costs that are available from MedMutual, the primary medical liability underwriter in the state, for factoring in their medical liability cost, and came up with a formula for for this year for 2019, 2020. As noted earlier, we are talking with HSCRC about the integrating park standby expenses into hospital rates in future years. So running through this calculation, what we have done is the key hours are what they reported to us in standby hours, which are the fourth column from your left. You have trauma hours per year, hours in the OR, and the total standby hours by specialties. We are assuming there are approximately 4.1 trauma physicians in each of these categories, and the gap between hours in the OR is standby hours that have been calculated by Park and confirmed by the comptroller. We then applied the reasonable compensation equivalents for each of those categories, adjust those figures by provided 5% adjustment for continuing medical education and apportion malpractice in the same way, applying the fractional part of total hours attributable to standby to derive malpractice adjustment and get a total by each of those four specialties, which yields a total on-call stipend to Park this year in the amount of $2.4 million. Keep in mind that we have a $3.9 million surplus. We expect that year in, year out, we're going to put about $1 million back into that surplus, which means we can't do this every year, but we can do this for 1 year. And that's what we've elected to recommend to the commission, that we make a 1-year direct payment as we are permitted under the statute to do. But then in future years, work with HSCRC so that their reimbursement is rolled into rates and is consistent with the mechanism under which the other trauma hospitals are paid. I would point out to the commissioners here that the fact is that the other trauma hospitals were kind of supportive but concerned that this would go on for endlessly, that they would draw down the trauma fund, which all of them draw from, and drive it into insolvency. And I think that everyone felt comfortable when we made the commitment, stated that the staff would recommend to this commission that it be done on a one-time basis only. And then we work with HSCRC in future years to pay them consistently in the same way others are paid. So what we're
what happens if HSCRC does not work for us? What happens if it doesn't roll into the hospital rates?
Well, we wouldn't be able to then pay Park at the same level that they would claim is appropriate for standby, because the fund would not sustain it. There is a formula that we would go through, and I'd have to consult that if the fund cannot meet demands. And I think that not having the statute in front of me, it kind of is on the formula of last in, first out, so that if there was an insolvency, the last funding responsibility would be the first one taken out. There is one qualification, is that before we went to that scenario, we would recommend to the commission that we lower the reimbursement rates that we're making from 105% to 100% of Medicare, which would recover a bit of that. We're not required under law to pay 105%. We've made that determination in 2016 to reflect recognized complexity in the fund.
And is there any circumstances where we're liable to pay more than is in the fund? In other words, is it true insolvency where we have debts that exceed our liabilities, or is it more just the fund?
We are given the authority to balance the fund.
Okay, so no more payments are made?
No more payments can be made if we cannot meet those obligations.
Is
And-
HSCRC aware that we're going to be asking this?
Yes, conversations have already been started. And, you know, although there's not been a formal commitment, they understand. And I believe they're.
But they've heard it and not went no.
That's right. That's right.
Okay.
Okay. So the intention is through 2021, we would continue to reimburse at 105%. We would account for the Medicare, Medicaid differential for the Medicaid obligations we have, and we would reimburse Park from 2020 directly from the fund. And in subsequent years, we would roll those into standby rates after in consultation with HSCRC. The point, if we can't do that, we would have to scale down payments to align obligations with revenue from the fund. So that the next step is it will be the release of the report. So I did note that we lost one commissioner in the midst of this report. I think that we can count our commissioners, our commissioner that is recusing as a quorum. Counselor, can you advise us on that? Because we do need a vote to release it to the commission, to the legislature.
Statute says that a majority of the full authorized membership of the commission is a quorum, and that decision can be made by a majority of the quorum present.
So that my interpretation is that the fact that one is recusing continues, our quorum continues, but that the individual is not voting.
That's reasonable.
Okay. Mr. Chair.
So we would need at least 4 votes.
Yes.
All right. Do I have a motion to approve the approval of the report for release?
Motion.
Got a second? Is there any discussion? I had a question, and I think you answered. I just want to make sure. So this fund, we could run it to a zero balance every year. We have the authority to say, if say the funding were cut in half, we could adjust the payments to pay out the funds without incurring.
Well, I would caution you. I mean, we could.
I'm not saying it's a good idea.
Yeah, we could. The way we could do this is elevate reimbursement levels. Say instead of 105%, we decided to pay 180%, which.
I was thinking more the other way. If our funding went down, we'd be able to reduce our.
We could. Yes, we could.
Okay.
There are. Keep in mind that if we went into insolvency, the first thing that would happen is the comptroller would pay would issue our checks, and then would tell us you have a deficit. How do you plan to make it up? And so it wouldn't be like bouncing checks, but we would basically be borrowing from the comptroller with the expectation that we would square up revenues and expenses at the end of the year. If we couldn't do that, we'd kind of be on a payment plan arrangement with, we'd have to explain to them how in the future year we would align revenues and expenses to make it work out.
Are there any other questions? Okay, well, all in favor? Any opposed? You got your 4 votes.
Yeah, I rushed through this very quickly. Some of you have seen it before. A couple of you have not. If you want to talk further about this, I'll be happy to take some time to cover this at an occasion that's convenient. I know we have one other presenter here, and I wanted to be respectful that they've come all the way from Maine to get here, and weather being what it is sometimes challenging to catch those return flights.
All right. Good to be back. Hope you all missed me. Agenda item number 7, an assessment of the impact of establishing a mandate in the private insurance market for new EMS models of care. Matt Kukla, Senior Health Economist for Barry Dunn, presented a draft report estimating the impact of proposed mandate of coverage for new models of EMS care in the private health insurance market in Maryland. The report's a response to a request from the chairs of Senate Finance and House Health and Operations Committee of the Legislature. The report complements recommendations. Okay. Complements recommendations from MIMS on the new models of EMS care by providing evidence-based estimates of costs if these programs are covered by health insurance.
Thanks for having me here today on behalf of Barry Dunn. Next slide. For the sake of time, I'm going to keep this presentation at a fairly high level, but happy to field questions and answer any details as those arise. Given access and cost-related issues with ED use, our objective here was to analyze the medical, social, and financial impact of mandating fully insured commercial insurers to provide coverage for 3 potential EMS benefits. The first is treat and release, which is a model aimed at identifying low acuity patients who have called 911 and would reimburse them for providing care on the scene to a patient. Alternative destination as a benefit means that EMS would transport patients that have called 911, again targeting low acuity patients, to an alternative destination such as urgent care or another clinically appropriate setting instead of the emergency department. And mobile integrated health is a slightly different benefit. It is not necessitated or prompted by a 911 call, but essentially EMS partners with healthcare providers to conduct home visits where they assess, treat, or refer patients to the appropriate healthcare setting or provide community resources. So the target population for MIH benefits are those high utilizers of the ED, frequent 911 callers, or those at risk of a hospital readmissions. While I'm going to highlight here a couple of the key takeaways from the literature on medical efficacy. For the alternative destination as a benefit, Maryland currently has 2 programs in operation. There are similar alternate destination programs happening around the country in different states. 2 additional ones in Texas, another one in North Carolina that focuses on behavioral health. The overall evidence for quality and outcomes is fairly limited given the nascency of a lot of these pilot programs. But for example, in Houston, there were some findings that EMS time until being back in service, that is how quickly EMS providers can be recirculated to move on to their next call, declined by 44 minutes relative to controls. They have found no significant differences in mortality or patient satisfaction with those benefits relative to the traditional ED use. The study in North Carolina also found a relative decline in length of stay for those alternate destinations relative to the emergency department. Mobile integrated health has 9 pilot programs in Maryland, broken up by county. So there's a lot of activity going on in this space. One in particular, happening in Baltimore, has found significantly higher patient satisfaction, and through the interventions that are occurring in MIH have increased identification of a range of problems from medication related, durable medical equipment, and other socioeconomic challenges that patients face.
I think it's the city, not the county.
Oh, the city.
Yeah.
I'm sorry, this is Baltimore City.
Baltimore City.
Yeah.
Baltimore City.
There's
sorry,
a typo
sorry,
on this.
Typo.
Sorry.
Got it, okay.
Yep.
I'm the medical director of the Baltimore County Fire Department. I know nothing about a program like that.
NIH programs tend to be very diverse. They target different populations, different clinical services, and so there's a lot of variance around health outcomes, patient satisfaction, depending on the program description. Overall, across the three different benefits, there has been evidence from pilot programs that emergency department visits have declined relative to control groups. But I wanted to highlight here the mobile integrated health evidence base because it is significant. In this table, you can see evidence from 5 different geographical areas and different pilots, all of which generally find significant declines in not only ED visits, but hospital admissions, number of 911 calls, and hospital readmissions associated with those programs.
And just to be clear, these are mobile integrated health programs.
Yes.
You're looking at not treat and release or.
Correct. Yep.
And you're comparing them to controls, but when you say controls, you mean controls who have no intervention at all.
Correct.
You're not comparing them to traditional interventions of home health, for example.
Correct.
Which is where the obvious comparator, right? Home health.
Right.
They're doing the exact same things home health agencies do.
Yeah. So these, because there are a number of evaluations that we're pulling this data from, they all vary in their study designs or methodologies. So some of them are more robust than others, but most do.
I think it's just important for the commission to think about this in the context of home health because we regulate CON for home health. So if these programs are coming into existence, they're coming into existence right alongside home health. We're going to have to start to figure out where that line is between mobile integrated health and home health agencies.
Is there a difference in population that they serve, or is this providing a service to patients who don't quite meet the threshold for qualifying for home health?
I
I don't think so.
I know at least one program in the state, and obviously we've got 9 pilot programs operating, specifically excludes patients that have home health services, so they don't qualify.
They don't qualify or they haven't been ordered?
When they get a referral for a patient, if that patient has access to home health services, they don't provide the mobile integrated health.
Right.
So it's serving a different population.
Well, but is it because they don't qualify or because they haven't been set up, they haven't been ordered?
I don't know the answer to that question.
So it's not they don't qualify necessarily. Maybe the same population. It's just that there's no duplication of those services occurring.
We were also asked to explore payer options in the event that there might be some induction of demand for additional healthcare services resulting from these benefits being mandated. Of course, those options will depend on regulatory requirements for payers. And naturally, the uncertainty around how payers will respond to this mandate or any regulatory changes make it somewhat difficult to accurately forecast the impact of these models, which is fairly standard. Patient cost sharing, benefit design, utilization management, these are all demand side options they can employ that'll impact patient care delivery decisions, as well as the volume of 911 calls. And then, of course, the underlying payment structures and rates will impact EMS providers, where they transport patients to, types of services provided, care intensity, among other. Our financial assessment is really the bread and butter of this report. We apply data from a range of sources. From the commission here, we have sent out surveys to commercial insurance carriers, asking them questions about their intended responses. We've looked at claims data, eMeds data, academic literature, and other survey data for pilot programs. This slide focuses on our analytic approach. I don't want to get into too much of the weeds because I will talk about these as I present the actual findings, but what I want to describe here is that while the underlying methodology does vary across the three models and how we approached it, ultimately what we're doing is we're calculating costs, we're calculating savings, and looking at the net difference between them to identify the financial impact.
When you were calculating costs, I didn't see it in here. Did you include administrative costs, billing, payments, any medical utilization review, medical management, setting the policies, that sort of stuff?
Yeah, so most of the time our costs are going to be based on claims paid. So that I guess theoretically should be baked into the amount of payment that's being made from payers.
Or your costs here were based on the costs of a pilot. They wouldn't have any of that administrative overhead.
Sure. So our unit costs are based on either claims where they do occur. So for example, there was one commercial carrier who is implementing one of these models, not in the state of Maryland, and so they would give us their rates that they paid, and then the rest would be coming from pilot programs and how those are working.
So you're looking at cost from the patient's perspective, not cost from the system's perspective in delivering the care.
And then the other question I had is, since 13% of the pilot program enrollees are covered by commercial insurance, you're making the assumption then that the charge would be a cost in commercial insurance rather than we're running this program and we're getting some reimbursement on some patients and none on others. Let's set the cost appropriately in view of the person making the charge. In other words, a concern that one often finds in the commercial market is you're paying for more than just the cost of the care to the commercial member.
Your cost shifted for all of it.
Yeah, there you go. That's a better way of phrasing it.
For this slide, what I'd like to sort of draw your attention to is that the underlying population that is being affected by this particular mandate is very small. So we're looking at the fully insured commercial population, and so looking at that first table, what we see based on the most recent data are the total number of 911 transports in the state at 624,000. And based on various data sources, the number of commercial fully insured 911 transports is a very small percent of that. We then take data from pilot programs and other parameters to find that only 7.8% of those commercially insured members would be eligible for this particular benefit, and of those, 70% would choose to elect them. And so ultimately, our net financial impact that we'll get to are going to be based on these relatively small numbers. For the treatment release, on the left-hand column, you see these cost estimates. On the right, this is how we calculate savings. We calculated costs from the treatment release model by estimating the actual cost of delivering treat and release services, as well as clinically recommended follow-up office visits. We then multiplied that by the anticipated number of treatment release events for the patient population of interest.
These are costs from the patient's perspective.
These are costs that payers would incur.
That's the patient.
Yeah. For the savings estimates, then we assume that a treatment release event would be a substitute for an emergency department visit. So what we're doing is calculating the cost of an ED visit in transports multiplied by the number of treatment release events. That would be a substitution and taking the difference. Next slide. The alternative destination models that we used for our cost estimates, we calculated the cost of this particular model by asking how much would frequency of 911 calls increase, or the percent of calls that were eventually transported, how much would that change as a result of this added benefit? Finding that there would be very little increase in demand or use resulting from this particular benefit. Our estimates only about 0.3% of all 911 calls made. And so as a result, this, the net financial impact is really driven by these savings estimates, where we look at the difference in cost between an ED visit and a visit to an urgent care center. That is the savings, and we multiply that by the total number of actual transports that would be going to an alternative destination. Next slide. And finally, for mobile integrated health, to estimate costs, we ended up taking costs from the many different pilot programs here in the state of Maryland, and because the benefits and those types of pilot programs are very diverse, we took the average cost for an MIH service, and we multiplied that by the number of expected MIH services. To identify savings, we looked for the cost of ED visits, as well as the cost of a hospital readmission, and then consider the number of ED visits and admissions that would be avoided as a result of this particular benefit.
Can we go back a slide? I just want to make sure I understand that, again, not to beat on this, whose cost this is, but the cost shift that's missing here in this calculation, right? So what you're failing to consider in this model is that when these don't result in ED visits, these presumably these additional ED visits that are attached to these visits that go to urgent care instead, are associated with very little variable cost to the emergency department they go to, right? Because you've got a fixed infrastructure in place taking care of them. So when those visits come out, even if the HSCRC takes that volume out and doesn't pay the hospital that in the GDR anymore, they're only taking it out at a 50% variable cost factor, and there's no real variable cost in there, right? So the hospital loses 50% of the revenue, which means that the payer it takes away only half. The only thing that the payer sees as an advantage is half the cost of the ER visit coming out, not all of it. So you're paying half the cost of the ER visit and the additional cost of the urgent care on top of it. And this model doesn't consider that.
Correct.
Right. That's an important statement to include in the report, I think, so that people really understand that you're not. In Maryland, it's a very difficult equation every time you do something like this, unless you're actually taking true variable cost out.
This is sort of the broad takeaway from the financial impact assessments, finding that the overall net financial impact of these three models is relatively small, but it does accrue savings, and these numbers are in thousands. On the columns, you can see that for each of the models we have our cost, savings, and net impact, with the net impact being in bold. And then we provide bands around different scenarios based on whether we want our assumptions to be more aggressive or more conservative. And so the numbers that you see up there are the aggregate spending and net financial impact, as well as the per member per month changes to premiums that would result from these models being implemented. As always, there are limitations to projections and forecasting work. Our projections are only as robust as the underlying data, the evaluations, studies that we're pulling from. These estimates are also averages, so there's likely to be variation in its impact on patients and individual payers, depending on how they respond. And then, of course, we have conducted our analyses looking at each of the models separately rather than additively. And given some of the overlap in what they aim to accomplish, there's likely to be an effect on utilization and cost spending savings if they were combined. So that's something to be aware of. And that's it. Happy to questions.
I think Chair Hollis' point is a good one, though. Looking at the summary results, if you have the savings for the MIH program, you have a 12-cent cost and a 11.5 cent, if I do my math right, savings. So you're actually a half a penny per member per month behind there. I don't know how we could like say these are the cost of benefits in our market without addressing that. Maybe that's a caveat that should go into the report.
Well, it's just a piece of it and goes in the report. I would say that the way you have to calculate it is that the ED visit unit cost is half of the charge, because that's the savings that would come out by that visit coming out, assuming that you had 100% compliance, which the urgent care unit cost at 90 would be 240 minus 90. So it's still positive. It's just not as positive.
Yeah. And I think that the cost estimates here are a function of your unit costs as well as the overall magnitude of events or patients for which this is applicable. And sort of the big takeaway for us is that primary reason why we're seeing such low numbers, even if we tweak at the margins, is that we're dealing with a very small percent of overall transports for which a lot of these models would be applicable, at least in the fully insured commercial population in the state of Maryland.
Oh, that's right. It struck me on looking at the different categories that the MIH program compared to, say, the transport program raised different questions of infrastructure. The transport program, you've already got an ambulance, you've already got drivers, you're already in there heading somewhere, and just heading to a different place seems not to add infrastructure costs, right? If it weren't for the hospital billing issue, you might just say you're pointing the hose and you're paying the same amount to go to different destinations. But MIH requires building an infrastructure of additional providers. And it would seem to me that that would focus on the benefit if you have to build a new infrastructure of providers. Does that show up in your analysis?
I want to make sure I understand your question. So did we account for the cost of
MIH, if I understand it, you're going to need like nurse practitioners or clinical social workers or whoever it is going to come along and ride along and provide the care that you don't need today. If you're not assuming you're not going to expand someone's scope of practice, then where do those, because it seems like that adds some fixed cost to the system. Maybe that's not purely episodic. Does that show up?
Yeah, so those are, and again, it depends on how each of the pilot programs were designed, but that typically would be baked into our cost for the MIH services that was about $2,000. And so, one of the things to consider for MIH in particular is that the bands are likely to be greater than they are for some of the other programs, because it depends on how the benefits designed and implemented, types of services and populations, whereas release in all destinations tend to be more more simple.
The assumption that you're not expanding people's scope of practice is not true, because in most of the successful programs nationally, they have added what's called community paramedics, whose scope of practice is substantially broader. So you don't necessarily, for the home visits, need to bring other people on. We haven't done that in Maryland yet at the same level, but that's certainly an option going forward. But there's a crossover here between home health and community paramedicine that is, where the line is gray at least, at the least. And I'm not sure we've really considered that given our role in regulating home health. And the home health agencies come in and say, hey, what about the CON issue that we have? Where's theirs? I think we have to be prepared to answer that and think about that one.
And I think the point I was getting to is not so much a fault of your analysis, it's the thing you were asked to analyze seems rather amorphous in that category.
Within MIH?
Yeah, it could be this, it could be that, it could be this, and you've come up with a number because you were tasked with coming up with a number, but I'm not sure that's all that useful a number, given the amorphousness of what you had to analyze.
Yeah, and I will say that because a lot of the programs, especially in the state of Maryland, are relatively new, what we know from just evaluation work is that the longer time you have to study something, the more you can work out the kinks, the greater your confidence and robustness in findings. There's just very few programs, and those that are active tend to be pretty recent. So.
So we'll be returning this report to the chairs that asked for it, and I think it is a useful reference document. There are ongoing policy conversations going on in the state about these programs. So this is one other thing that adds to that conversation.
I think we should emphasize that we did get quite a bit of insight, not a lot of data, but insight from Anthem, who have voluntary programs running across the country. The take up from them was not a lot yet. I think that one argument for encouraging private payers, even though maybe populations are not necessarily the specific ones that would be covered extensively by the population, is that EMS can't make sort payer issues out on the field. Alternative destination and treat and release, if it's not available population-wide, it's very hard to anticipate that EMS is going to be able to make determinations on who's eligible and who's not. But that adds another complexity to the alternative site, which is the network issues that our government relations colleagues and all the payers, for instance, a really compelling issue for that particular innovation. There's a lot of interest in the EMS community in this, but implementations challenges abound.
Yeah, there's no question this is one of the hottest topics in EMS right now. There's an awful lot of enthusiasm for these programs. The data is lagging way behind the enthusiasm. But I applaud the enthusiasm. I mean, I think it's yeah. So that's not necessarily how we change. In general, just studying the cost effectiveness of pilot programs is important.
No, I'm not
broad
saying that. I'm just saying that when there's a lot of enthusiasm quickly,
yeah,
it does take time for the data to catch up because people are trying to do things intentionally, and that means the data is slow.
I want to thank our actuary. We can promise you that if you come back, you won't be last on the agenda.
This is good.
We're here too. It's only 4:30. I know it's getting dark, but
I try to get you guys out of here early.
Yeah, you can have next Wednesday off.
I got some more questions.
All right. Do I have a motion to approve an assessment of the impact of establishing a mandate in the private insurance market for new EMS models of care? Second? Very good. We have 7 commissioners here. I believe that's a sufficient quorum for this activity.
I think
Is Sue Ellen still here?
Dr. Thomas is still on the line.
8.
Dr. Thomas is dialed in. Can we?
Are you there, Dr. Thomas?
I hear him.
Yeah.
Yeah.
Dr.
He should
Thomas?
be on.
I think we all heard it.
He's there.
Sue Ellen?
She's gone.
Sarah's here. We do have an attorney watching.
We need 8
We
people
need 8.
to release a report. We released the report saying we had 7 present.
That was scary.
Look for Dr. Thomas. No, I don't see him.
Just see.
My goodness.
Just a second.
Hey, Ben?
Dr. Thomas, you're on the speakerphone. Were you able to hear?
Yeah, I was hearing the whole thing when I was speaking. You couldn't hear me, and they have me muted on that end. So I vote to approve.
We have a motion and a second, and we've got 1 in favor. Do we have any others in favor?
Wait a minute, I have a concern. I would like to see an acknowledgement that this is not an analysis of the costs, including the all-pay rate system, things like that.
Yeah.
Either in the cover letter or in the report.
Yep, we can take care of that.
I think we can put it in the cover letter.
Yeah.
All right. All opposed? We have 8 in favor, none opposed. Thank you very much. I would, I'm sorry, Ben, would you like to share a brief update on upcoming activities for January's public meeting?
Yes, we expect the usual menu of events. We would have several CONs. We'll be back with you with a final report on potential models. David will have a breach report on information breaches in Maryland healthcare institutions, principally hospitals. And we'll have our first legislative update. And Ken's team will talk about reimbursement, professional services reimbursement for 2018. So 7 or 8 agenda items. We will be in touch as time pursues. I wanted to note one additional thing because I think we had a lively discussion, and that is, I'm not going to add too much to that, but you are the referees. Referees today in today's environments are increasingly under stress and issues that come before you. Oftentimes you're called upon to make a call. That is not oftentimes recognized or appreciated, and I want to thank you all for doing that.
Thank you. Thank you to staff for an outstanding job putting all this together today. Happy holidays to everybody, and we'll see you in January.
Merry Christmas.